We're about to get started. I just would like to ask you all if you're carrying cell phones, if you wouldn't mind putting them on silent or vibrate. I also want to let you know that this community forum is being webcast. So folks all around the state will be able to access the conversation that's going to take place tonight.
How are you? I'm sorry.
Congressman Rahal?
Thank you. Let me begin by thanking everybody for being here this evening, especially all of the good people at the Irma Byrd Center for Higher Education and Concord University for giving us the opportunity to come together, allowing us to use your facilities and your expertise on the communication equipment. I am so honored to welcome our distinguished panel this evening. They are your partners, they are our partners in this fight. They will provide a perspective of the federal resources, federal response, that is, to prescription drug and heroin abuse. And before we introduce them, I want to thank each of you that are here, not only for being here, but for your individual and your collective work as well, because you know better than I do how that is so important. And it does take that collective effort to combat this issue, and we all have to work together. I'm pleased and very proud to have the personal participation of the Director of the White House Office of National Drug Control Policy, Mike Botticelli. We've been together all day today in Huntington, had a very good day with the mayor and the law enforcement officials of Cabell County, touring the areas there, seeing what's worked, what needs to be done yet, and that's what we want to continue here in this part of West Virginia, starting with this evening and continuing tomorrow in the southern counties. I do truly appreciate Mike's personal involvement. It's been fantastic, and his continued commitment to our families, to our businesses, to our communities, that in case after case are being devastated by drug abuse. But perhaps most importantly, Director Botticelli, you and our federal partners will hear from my fellow West Virginians. You'll hear from them firsthand what federal resources have been effective and what efforts or resources are needed to continue to address the problem in our state. All of us tonight will hear from individuals that I have invited from various communities in West Virginia. These hardworking, dedicated people are representing our law enforcement, our family courts, our community service organizations, and healthcare providers in the southern part of West Virginia. Their service and commitment in our pursuit of solutions for substance abuse in southern West Virginia is vitally important. We must do all we can to ensure that we have the resources and the support to do what needs to be done, what must be done, if we are to wage a successful battle against substance abuse. Mike, what you have helped us build upon is reaching new vistas in West Virginia. We appreciate the inclusion last December of Raleigh and Wyoming counties in the Appalachian HIDTA, that's the High Intensity Drug Trafficking Area Program, and the financial resources that you bring to our efforts to fight this scourge. We want to keep building on this work and tackle substance abuse from new heights and new quarters. So with that said, I'm going to introduce our panel, not necessarily in the order which they're seated, but the order that I have them listed, and that's I've already introduced to you Mr. Mike Botticelli, our Director of the White House Office of National Drug Control Policy. To his right is Dr. Daniel Salson, the Acting Director, National Center for Energy Prevention and Control at the Center for Disease Control and Prevention. The far right is Dr. Nora Volkow, the Director, National Institutes for Drug Abuse. Coming back this way one, it is really a hopscotch order here, is Dr., but they do have name tags from, yeah, okay, is Dr. Eleanor McCants-Katz, the Chief Medical Officer, the Substance Abuse and Mental Health Services Administration. Sam says it's known. Mr. Christopher Taver, the Senior Policy Advisor, Bureau of Justice Assistance, U.S. Department of Justice, and a man familiar to all of us, second to my right, our good friend and dedicated U.S. Attorney for the Southern District of West Virginia, Mr. Booth Goodwin. So let's give all of our panel a round of applause for being here. And before I turn it over to the panel, let me say one good word of good news, actually, and I didn't want to overlook this. But West Virginia has been chosen by the Center for Disease Control and Prevention, CDC, to receive more than $1 million over the next 3 years for the development of an anti-drug program that would serve as a model for the rest of the nation. Dr. Tom Frieden called me on this a couple weeks ago. We discussed it, and while he couldn't be here today, he has sent Dr. Sausen, who's going to explain this award in a little more detail. But this significant infusion of federal funding will enable West Virginia to strengthen its prescription drug monitoring program and develop new drug abuse prevention strategies, allowing our state to gear its Medicaid rules toward better protecting against drug abuse and overdose. West Virginia is one of only 6 states selected by the CDC to participate in this national initiative. So I'll ask Dr. Sausen to give us details of this terrific Boost for Prevention Award, as it is called. And I'll turn it over to you.
Thank you very much, Congressman. Thank you for your support and your leadership and your interest in the prevention of prescription drug overdose. We know that the states are on the front lines of this epidemic, and CDC is committed to providing states with resources, with expertise, and with data that you need to protect patients and save lives. Earlier this year, we announced that we were initiating a new program to support states, the Prescription Drug Overdose Boost for State Prevention. This program gives a surge of resources and direct technical assistance from CDC staff to advance the most promising prescription drug overdose prevention strategies. Over the next 3 years, CDC will provide $6 million to 5 states, actually, so even more exclusive.
Wow.
Thank
you for correcting me.
So today, it's a pleasure for me to be here and announce that West Virginia, acting through the West Virginia Violence and Injury Prevention Program here, will receive more than $1 million over the next 3 years to improve public insurance mechanisms and to implement and evaluate state-level prescription drug overdose prevention policies, such as those in the provision of the Senate Bill 437. The advances made by West Virginia and the other 4 states will serve as a model for other states so that what works best can be reproduced by others fighting this epidemic. CDC is committed to providing support and assistance to West Virginia, and we look forward to the progress that the state will make over the coming years in addressing prescription drug overdose. Thank you again for the opportunity to announce that.
Thank you. Thank you very much. We appreciate that. Now turn it over to our partner and our big help and friend, Dr. Mike Botticelli, Mr. Mike Botticelli, the director of
I play doctor sometimes.
I know you do. Thank you, Mike, and we really appreciate the time you've taken from your schedule to be here and your help to us on this issue. We really thank you.
Great. Thank you, Congressman. And it's really good to be back in West Virginia. While there's significant problems here in West Virginia, I've also been able to spend a lot of time over the past 2 times really looking at tremendously committed people who are doing this work and really implementing, I think, good, innovative programs. And, I do have to say it all starts with leadership. And I'm really grateful for the gentleman, and I use that word sincerely, to my right, who I think has just been heroic in terms of his leadership around this issue. Not just for the people of West Virginia, but also for this nation. And I think we have a lot to thank him for in terms of the work that we're doing. And quite honestly, I think that's why a lot of us are here tonight, because of your dedication to this issue.
Thank you.
As the Congressman talked about, we did have the opportunity to spend the day in Huntington today. And it was really emblematic for me of kind of not only highlighting what the problems are and what we need to do, but also highlighting the solutions to our issues. And, we saw community leaders, we saw the mayor, we saw the police chief, we saw local law enforcement, treatment providers, and public health folks working together in partnership with the community to really deal with this issue. And so we know that we can make an impact in terms of the work that we're doing. And honestly, I think all of us at the federal level feel like we need to work together. But part of our prerogative and part of our mandate is to make sure that we get the resources out to the local communities to make sure that you have the resources to deal with the issues that you need to struggle with. You know, I can say this with certainty that our office, the opioid issue, the prescription drug and heroin issue is our top priority in terms of the issues that we are dealing with here. And I'm really happy to say that we do have a strong partnership at the federal level to focus on these issues. I'll just spend a few minutes talking about kind of what our national plan is and how that affects the local issues. Certainly, we know we have more work to do, and I really look forward to a discussion about kind of things that are working well. So first and foremost, I think we all know there's no silver bullet to this issue here, that there's not one single solution that's going to solve the issue, but it's only by a combined effort that we're going to get us to where we need to go. So in 2011, our office published a plan of how the nation was going to respond to the epidemic. And first and foremost, that starts with education. Educating all of us, and this forum is another opportunity to keep educating people. But really educating our medical community about the issues around addiction in general, but about prescription pain medication. There's just a report that the CDC released that showed we are now prescribing enough pain medication to give every adult in the United States a bottle of pain pills. And again, I'm not a doctor, but I play one a lot of times, and I know that we just don't have that much pain in the United States to be giving out that vast amount of medication. And so we need to educate our medical community about the appropriate use and safe prescribing of these medications. The second piece is really monitoring, and the Congressman talked about having vibrant prescription drug monitoring programs. We want to make sure that physicians understand as people progress in their misuse of medication that they often go from doctor to doctor looking for these medications. And we want to make sure we have good databases so that doctors can make informed decisions about those people. And the second piece, and we heard a lot of this today, is we want to make sure that those programs share data across state lines so that as one state like Florida implements, good programs, that they're not moving to another state to do that. We know that when people start misusing medication, that they get it free from friends and family. We often talk about this as an epidemic of the medicine cabinet, right? So you get a medication, whether or not you're supposed to get a medication, you got a medication. We heard it today. Maybe you get 30 pills, you take 3 and you put the rest in the medicine cabinet because, we've been trained as good consumers to let's hoard our medication for another day, right? So disposal has been a part of that. And again, this happens with our DEA and with our local law enforcement. And so I think we've had 8 drug take-back days, and over 4 million pounds of medication have been given back in those programs. So we know that we need to get it out of the supply. The fourth is enforcement. We really need to make sure that we're cracking down on pill mills and making sure that we're dealing with the trafficking issues and the drug. We know that we can't arrest our way or incarcerate our way out of the problem, but we also know that there's some bad guys out there that we need to have in jail, and so we need to make sure that we have good enforcement. There are 2 other areas. One is making sure that we have good prevention and treatment programs. We know we have a significant gap. Only about 1 in 9 people who have a substance use disorder get treatment. So we want to make sure that we are giving our state and our local folks the resources they need to have good prevention programming and good treatment services. And we heard a lot about that today. One major way we do that is through our Drug-Free Community Grant Program, which we have one here. And the last thing I'll talk about is just the dramatic increase in the overdose deaths that we've seen here in the United States. So the last year for which we have complete data, we have 110 Americans dying every single day of a drug overdose. The vast majority of that is still attached to prescription pain medication, but increasingly we're seeing skyrocketing rates of overdose deaths as it relates to heroin. And one of the things that we've been promoting is the use of naloxone. And naloxone is this incredibly safe, incredibly non-toxic, but incredibly miraculous drug in reversing an overdose. And we've really been calling on local law enforcement, who are often the first on scene, to think about you carrying naloxone. I was in Massachusetts for a long time, and we trained the first police force in the country on using naloxone. It's this very small town south of Boston, kind of reminds me of Huntington in a lot of ways. And the police force there have been able to reverse over 260 overdoses in the few years that they've been implementing this program. Clearly, we want people to go to treatment. We need to get people into treatment. People need to be alive to go to treatment. So it's really an opportunity to do that. I would just end by saying I know we have more to do. You know, we continue to have great support in Congress in terms of the work that we're doing, as well as the rest of federal government. So I look forward to hearing from you in terms of what more we can be doing. Thank you.
Dr. Sussex? Thank you, Mike.
Thank you again, Congressman, for this opportunity. Appreciate your support for the work we do at CDC. I also want to recognize and thank the women and men here today fighting this epidemic on the front lines. The people and agencies represented in this room are all needed. As Mr. Botticelli said, it takes multiple approaches, multiple disciplines on multiple fronts. While we still have much to learn about combating prescription opioid overdoses, we know more now than we ever have about the burden and who is at risk of prescription drug overdose. And we can work together to protect West Virginians and Americans across the country from this epidemic. I have 3 brief points I'd like to make about the burden and CDC's role. First point, deaths from prescription opioid overdoses are increasing at a faster rate than any other major cause of death in our country. Nearly 17,000 people die each year from prescription opioid overdoses. That's the equivalent of one person every half hour dying from an overdose of opioids, prescription opioids. And more than 400,000 people visit an emergency department for prescription opioid-related condition. Here in West Virginia, as you know, drug overdose rate is 3 times that of our national rate, the highest in the country. We know there are faces and lives behind these numbers, and we are working closely with states and our partners to tackle this epidemic and to ensure that what we implement works. And while we do that, we are assuring that we're providing effective care to people with pain. Second point, opioids, the drug primarily responsible for the prescription drug overdose deaths, are prescribed at alarming rates, and the deaths track very closely to prescribing rates. In the last 10 years, the amount of opioids prescribed and sold in the United States quadrupled 4 times. Yet there has not been an overall change in the amount of pain that Americans report. West Virginia has the 3rd highest prescribing rate in the country. That document published in July, the beginning of July, that was referenced, indicates that in West Virginia, 137 prescriptions were written in 2012 for every 100 people. Sometimes the treatment becomes the problem, and to reverse this epidemic, we need to improve the way that we treat pain. Third point, CDC uses science to create real-world solutions to prevent prescription opioid overdoses, while also making sure that people who need it have access to safe and effective pain treatment. We do this by gathering data to track trends and understand why prescription opioid overdoses have become epidemic. Second, we work with states and our federal partners to put into practice strategies that help prevent high-risk prescribing. For example, through the Prevention Boost program, we will work with West Virginia to evaluate the state-level prescription overdose prevention policies and the prescription drug monitoring program to determine how well it's working and what can be changed in order to make it more effective. And third, CDC seeks to improve patient safety by providing doctors with data, with tools, and guidance so that they can make the most informed decisions for the safety of their patients. We know that progress does not come easily, yet we also are confident that West Virginia is well poised to make a difference, ultimately reducing prescription drug overdose deaths, and CDC is committed to helping you as you progress through that process. Thank you.
Thank you. Thank you very much, Dr. Sussex. Dr. Nora Valcau is the director of the National Institutes for Drug Abuse, and like many on this panel, I have heard her speak and heard her professionalism before. We were all together at the National Drug Abuse Summit in Atlanta earlier this year, as Mike will recall as well, which was convened by my co-chair of our Prescription Drug Abuse Caucus in the Congress, my good friend Hal Rogers, Republican from across the line in Kentucky, and also chairman of our House Appropriations Committee. Dr. Valco, welcome. Good to be with you again.
Thanks very much, and thanks very much for inviting me. And I met the congressman on that meeting, and he had organized a meeting of representatives from the community of West Virginia. And what I heard there impressed me so much that I invited myself to West Virginia. But he made it happen and possible. And the issue was, I mean, I represent the National Institute on Drug Abuse, whose our mission is to actually use science in order to develop knowledge that would enable us to treat and prevent diseases, in this case, drug addiction. But in my perspective, in drug addiction is a disease of the brain that can be prevented, and we cannot say that of many of the other diseases. So in that respect, it gives us a tremendous advantage. But for us to have effective prevention strategies, we need to understand the unique complexities of the particular groups that may be facing the problem. And while it is correct that drug addiction is a disease of the brain, it emerges as a part of a social structure. If there were no drugs, of course, we will never have the problem of drug addiction. And indeed, the problem that we're facing right now of addiction to opioid analgesics and their associated risk for overdoses is a relatively new problem. And when I came to the NIH 11 years ago, I was struck for the first time by the numbers that were emerging, because in general, you do not expect teenagers to be abusing opioids. And access to the analgesics was changing and has changed that epidemiology, such that now teenagers prefer opioid medications over many of the classical illicit substances. Now, why is that possible? Why is this happening? Well, opioid medications, opioid analgesics are the most potent medications that we have to control pain. And they do so by stimulating opioid receptors in areas of the brain that regulate pain. The problem is that we have these same receptors in areas of the brain involved with reward. So that when someone takes a pain medication, not only are they stimulating the pain centers, they're also profoundly activating reward centers. And whereupon this type of medication is not only a potent analgesic, but unfortunately, it is a very addictive drug. Now, for many years in medical practice, and still in many medical practices, it was believed that when someone has pain and is prescribed an opioid medication, they will not get addicted to it. And that created an overconfidence in physicians that started to prescribe these medications without clearly recognizing that some of their patients were starting to get addicted. Now, we know that is indeed the case. Not everybody becomes addicted, like not everybody that gets exposed to alcohol or tobacco will become addicted. And one of the areas of research that we study is what makes someone vulnerable to addiction. But we know that having pain by itself is not a protective factor in the process of addiction. Now, because this is a type of drug that's also what we've started to investigate is then why is it, okay, it's rewarding, but there are other drugs, so why is it that the communities are shifting towards favoring them? And one of the things that has made their acceptance so wide is the misperception that because these are medications that are given by the medical community, they are less dangerous than illicit substances. And that is a misperception. Opioid medications are as dangerous and as addictive as other illicit substances. And this needs to be communicated to the lay public so that they realize that this is not in any way an alternative for getting high with something that may be less harmful. In the science that we do, and our mission is, of course, as I say, come up with knowledge that can solve problems of prevention and treatment. Now, I view the problem of opioid analgesic addiction and overdoses a really urgent problem. With the numbers that were cited, 17,000 people every year, my perspective is that we have an urgent situation that demands urgent actions. We can develop science that in the future will allow us, later, allow us to transform the way that we treat and even perhaps prevent addiction. But we don't have time in our hands. We actually don't have that luxury, and we need to do interventions right now to address the problem of opioid addiction. Now, as I was coming and I was thinking about it, because it's obviously the issue is what can we do? And I think that my colleague, as usual, so eloquently, Michael Botticelli, has delineated some of the action items that we currently have that, if implemented, could solve the problem of opioid analgesic abuse and overdoses in our country. What we need is the commitment to want to do it. And once we commit, realizing that this is urgent, we will succeed. This is a problem that unfortunately was generated by the healthcare system. And it was generated as a side effect that reflects in part the fact that in the healthcare system, we have not paid attention at all to the problem of substance use disorders or addiction. We don't recognize them as problems of related to healthcare, the public health, and yet they are. So physicians are not trained. They don't recognize if someone is addicted or not. What is the problem? If they have a patient, they prescribe a medication, they will not recognize if their patient is becoming addicted. And if it becomes addicted, they don't know what to do vis-a-vis treatment. So as Mr. Botticelli said, one of the most important things that we need to mount is a proper education and training of providers in the healthcare system of how to properly screen, manage, and treat pain patients, but also educate them how to properly screen, manage, and help treat substance abusers. The treatment of pain, the treatment of substance abuse, the education in both of these areas. As Mr. Botticelli also described, once you have the problem of drug addiction, we have treatments that work, and yet we are not using them. So enabling access of patients that are addicted to drugs like opioids to this treatment is not only going to help them stay away from the drugs, but it actually has been shown to prevent overdoses. Methadone and buprenorphine help in the treatment of people that are addicted to opioid analgesics. And yes, in the final event of someone overdosing, we so happen to have naloxone that actually can revert the overdoses and save the patient's life. We have the tools. And this is actually in the one hand that can enable us to prevent it, and in the other one, to actually treat those that are afflicted. And as I think about it, it's very, very different from other diseases. Let's think about Alzheimer's disease. We don't know how to prevent it. We don't know how to treat it. Here we have a very serious problem, but we have the tools that will allow us, if we implement, to resolve the problem. And I think that this is why forums like this one, where we all come from very different perspectives, and each one identifies their own approach in how to deal, are necessary such that we can succeed in implementing a strategy that can prevent and ultimately get rid of the problem of opioid analgesics, addiction, and overdoses. Thanks very much.
Thank you very much. Very good. Another vital federal partner in our efforts is the director of SAMHSA, and I'm sure many in this room are familiar with what SAMHSA stands for. She is Dr. Eleanor McCants, and Dr. Katz, we appreciate your coming to West Virginia as well, and the floor is yours now. Thank you.
Well, it's always such a pleasure to hear Dr. Volkow speak, because she's so eloquent about this issue. I'm going to take a few minutes to speak about this issue in terms of what SAMHSA is trying to do to help you. And I want to say thank you to Congressman Ray Hall for inviting me to see firsthand the issues that you struggle with related to prescription pain medication abuse here in West Virginia. And my thanks to all of you who are willing to share your perspectives with me tonight and with everyone on the panel. The prescription pain medication epidemic is one that has taken a huge toll and lost lives across the country, but nowhere greater than in West Virginia. West Virginia has the highest drug overdose mortality rate in the United States at nearly 29 per 100,000 people, a rate that has quadrupled over the last decade. Places like West Virginia, with a substantial segment of its economy based on coal mining, is a profession that unfortunately is associated with high rates of injury, high rates of chronic pain, and that pain is often treated with opioid pain relievers, setting the stage for those vulnerable to become addicted with exposure to these medications. But West Virginia has taken some inroads into fighting the battle against prescription drug abuse. They've enacted a prescription drug monitoring program that records controlled substance prescriptions to individuals obtaining these medicines in the state, and West Virginia requires its prescribers to check this program before prescribing. In this way, doctors can know what medications have been prescribed to a person and make better decisions about whether to prescribe pain medications or other medications that could potentially cause adverse interactions. In 2012, SAMHSA provided funding to the state to assist with the prescription drug monitoring program system to integrate with and become interoperable with electronic health records. West Virginia has laws to prevent doctor shopping, requires education of prescribers on safe use of pain medications, and through Medicaid expansion provides increased access to treatment services. In addition, West Virginia has enacted some laws that make it more difficult for pill mill type practices to become established by requiring that every patient have a physical examination prior to prescribing, a very important part of the physician-patient relationship. Pharmacists can ask for positive identification of people seeking prescription medications, and the state can now require those who are suspected of misusing prescription medications to obtain all their prescriptions at one pharmacy. These are all important components of an effective response to prescription drug abuse, but the problem is large and does not easily lend itself to resolution. There's more that can be done, and we hope at SAMHSA to help you with implementation of additional solutions that you think can help your communities. SAMHSA provides assistance to West Virginia through the Substance Abuse Prevention and Treatment Block Grant Program, funds which help provide prevention and substance abuse treatment, and through our discretionary grant programs awarded within the state, including drug-free community programs that seek to reduce prescription drug abuse through community partnerships and education about the risks of misuse of pain medications. In addition to direct funds from SAMHSA to West Virginia, the tireless work of Congressman Ray Hall and his staff helped to inform those of us who work at SAMHSA and other federal agencies to appreciate the scope of the problem, what's been tried, what's worked, what hasn't worked, and it helps us to better understand issues that hopefully will lead to our being better able to assist you with this problem. At SAMHSA, we believe that the problem of prescription drug abuse has to be attacked on several fronts at once. The first is to prevent the onset of prescription drug abuse through community efforts to raise public awareness of the dangers of misuse of these medications. The second is prescriber education on safe opioid prescribing, best practices in pain management, and the recognition and treatment of substance use disorders. The third is to have a strong program of opioid overdose prevention, including widespread access to the naloxone antidote. Lastly, it's very important to have wide access and easy access to FDA-approved medications to assist in the treatment of opioid addiction. That is addiction to pain medications and to heroin, which we are seeing more and more as pain medications either become too expensive or too scarce. This includes the 3 FDA-approved medications, the opioid antagonist naltrexone and the opioid agonist methadone and buprenorphine. SAMHSA has programs for providers to assist them in learning about the use of these medications. In the treatment of their patients with opioid use disorders, we have the Providers Clinical Support System for Opioid Therapies, which is a program of training and education for treatment of patients with opioid use disorders. The PCSS, or Prescribers Clinical Support System for Medication-Assisted Treatment, is a program to train physicians and other medical providers on medication-assisted treatment for opioid use disorders, and this program also provides the training needed for doctors to get the waiver to offer buprenorphine from their office-based practices to treat opiate addiction. SAMHSA also released the Opioid Overdose Prevention Toolkit last summer, which provides information to patients, families, first responders, doctors, and other prescribers on causes of opioid overdose, prevention of overdose, and use of the naloxone antidote. All of these resources are publicly available at no cost, and we've brought information that you can take here if you wish to learn more about these programs. We hope that they'll be of help to you and your communities. And I'll stop here. Thank you again for inviting me.
Thank you. Our U.S. Department of Justice is crucial in these efforts as well, through the many grants that we in West Virginia, especially our law enforcement personnel, have been able to obtain from the Department of Justice, including a grant just announced today to the city police in Huntington while we were there. From the Bureau of Justice Assistance, the Senior Policy Advisor is Mr. Christopher Traver.
Great. Thank you very much, Congressman, and it's a pleasure for me to be here on behalf of the Department of Justice. My agency is known as the Bureau of Justice Assistance, and we're a fairly unique organization within DOJ in that we're entirely about building capacity and partnerships at the local, state, and tribal levels. So we're entirely focused outside the Beltway. So it's great to be in communities like Buckley here in West Virginia and learn more about what we can do to help you directly solve your problems. We are first and foremost known as a grant-making agency. Many of you, especially those in law enforcement, may be familiar with our Justice Assistance Grants, or JAG grants. The City of Buckley Police Department is a recipient of a JAG award this year. I did look that up before I came here. But we do a lot more than the formula grants. We have a significant national policy office that is able to focus on issues of critical national importance. And the issue of partnership between criminal justice organizations and public health organizations has become very much a priority for us over the last several years. We've been doing work in this area for quite some time, but working with partners at ONDCP and other federal agencies across the room here, we've really tried to become the implementation arm in a lot of respects to all of the work that they're doing. So we are not the leaders in terms of doing research and policy analysis in this area, but we do want to be on the front lines of providing you the support to be able to implement and execute against the programs that are being described here. So in that vein, since about 2002, we've been administering the Hal Rogers Prescription Drug Monitoring Program, which is the program that enabled the implementation and enhancement of state prescription monitoring programs. I was fortunate to just be able to meet the gentleman from the State Board of Pharmacy and talk a little bit about the program here in West Virginia, which has been strong and active since 2002. We've placed a significant priority on building out the capability of these monitoring programs across the states. Obviously, it's an important tool for physicians. It's more information for them about the history, the substance use history of the patients that they're seeing. It's also a critical tool for law enforcement, for regulatory agencies, to be able to cut down on the abuse and misuse of these medications and the doctor shopping and diversion that happens with these medications. So these are obviously critical tools. Our emphasis in the last several years has been on expansion of PDMP capabilities. We know that many states struggle just to keep their programs active. That doesn't seem to be the case here in West Virginia. It's a very strong program. But across the country, we do want to provide the support that's needed. We have a significant array of training and technical assistance programs that are available to help strengthen those programs. We've also included a new funding category as part of that program that's about data-driven strategies at the state and local level with the PDMP as a cornerstone. So what we want to do is look at the overdose deaths that are occurring, the drug abuse challenges that are being seen by communities, and use the PDMP data as critical tools to analyze the problems and to address solutions. Many states and localities across the country are doing this to significant effect. We want to replicate those types of successes across the country and use our grant program to help do that. We also responding to something that Director Botticelli spoke about is the naloxone overdose reversal drug. The Attorney General recently hosted a meeting in Washington, D.C., where we brought together leaders, including those in Massachusetts, who have been on the front lines of distributing naloxone to law enforcement officers who in many parts of the country are actually first on the scene with those experiencing an overdose. This is still an emerging thing in the law enforcement community, and it's primarily happening in the northeast part of the country. But it's something that the Attorney General feels very strongly that this is something we want to and need to encourage. And he's encouraged all federal law enforcement to also examine their policies with the use of naloxone. But we'll be producing a toolkit in the very near future that is going to be a set of policies and guidelines that law enforcement agencies across the country can use to implement their own naloxone overdose programs. And we think this is going to be a really important piece. And again, it's a public health and public safety partnership with each of these sites working closely with their state departments of health and with strong medical oversight to make sure that these medications are administered appropriately and effectively. Besides our work on prescription drug monitoring, I also just want to mention that we have a wide array of grant programs, including those that facilitate the implementation and enhancement of adult drug courts. We have a justice and mental health collaboration program for those who are involved in the justice system that have co-occurring mental health disorders. We are the administrator for the Second Chance Act grant programs, and within that, one of the major focuses is on offender reentry. And as we know, those who are incarcerated that have substance abuse issues, that is an absolutely critical time when they're leaving jail or prison and going back into society, where they're extremely susceptible to relapse and require extensive treatment and support services. That's a key program for us. And also the Residential Substance Abuse Treatment Program, or RSAT. So we have a wide array of programs that we feel are very impactful in this area. Again, we look to the leadership of ONDCP and our federal partners here to help guide these efforts, but we hope we can continue to be a strong partner with you on the front lines of these issues. Our grants are all made available through our website, bja.gov, or all federal grants are posted at grants.gov. And we also have extensive training and technical assistance programs available through bjatraining.org. And if you have any questions about any ways we can offer you assistance, I'd be happy to speak with you. Thank you.
Thank you very much, Chris. We have a number of law enforcement personnel present representing all levels of law enforcement. And before I recognize Booth Goodwin, I do want to extend my sincere appreciation to all of our law enforcement. I know we have the sheriff of Pocahontas County sitting in the audience as well. And to our West Virginia State Police, many of whom are with us this evening, for their tremendous efforts and unwavering commitment in our fight against prescription drug abuse. I'm so pleased to tell everyone tonight that our West Virginia State Police has acquired some new tools in its arsenal to take back our communities. The West Virginia State Police has purchased 4 state-of-the-art incinerators, which will travel around our state to safely destroy and dispose of prescription drugs turned in by citizens in our communities. And so I'm going to ask our next speaker, familiar to all of us, to share his perspective on these incinerators and then additional comments that he wishes to make. But Booth Goodwin has been our partner not only in the efforts to clean up our community of drugs, but other efforts to clean up southern West Virginia as well and improve our quality of life. So I'm pleased to present to everyone our friend Booth Goodwin, our U.S. Attorney for southern West Virginia. Booth.
Congressman, thank you so much. It is so wonderful to be here tonight. I was very honored to be asked to join such a distinguished panel, so distinguished, in fact, that I felt like maybe I'm in a Sesame Street skit, like one of these things doesn't belong, and that would be me. But you know, I am really honored to be here, and I want to thank, first and foremost, Director Botticelli for coming. I think this is your second trip to southern West Virginia, and for your commitment not only to these efforts, but a very key tool that we have in federal law and state law enforcement in HIDA. We've got Kenny Berner, who is our State Director of Appalachia HIDA, here with us tonight. It has been a critical tool in our efforts. You know, in the Department of Justice, one of our efforts has been to start being smarter on crime. And the Attorney General announced an effort last August with that very name, Smart on Crime. And I think that Director Botticelli and the rest of you saw really kind of the product of that in Huntington today. Effort to bring the community together, law enforcement, treatment, and community members at large in order to combat this problem. And they've done it with remarkable success in Huntington. But I want to highlight that smart on crime doesn't necessarily mean soft on crime. In fact, it doesn't mean soft on crime at all. Last year, my office prosecuted more cases involving more defendants than we had at least in the last 15 years, probably since the crack epidemic, to be quite frank. And a lot of those cases related directly to prescription drug abuse and heroin, and especially this resurgence in heroin that we've seen. But that being said, that I am the first to admit that you're absolutely right. We cannot arrest our way out of this problem. It takes coordination, it takes collaboration among everyone, especially here tonight, to make it happen. And I just wanted to highlight a few things that we've been doing here in West Virginia that is directly in line with the national strategy to combat this problem. Of course, enforcement, we've been very aggressive in that, and we're very proud of our successes. As a result, I think that prescription drugs and the supply of prescription drugs on the street has been drastically reduced. But we've also turned to probably our most essential tool, and that is education. And that's what you led off with. And some of the things that we've done, and I see partners in the room tonight, Greg Puckett, Deborah Davis, and our faith-based communities, a whole host of others that have done so much around this. I wanted to point out as well, I've been fortunate to be joined by a number of law enforcement partners and community partners in going out and talking with schools. I've talked to 35 schools in my district so far and plan to talk to many more. But as I was doing that, I didn't feel like I was truly connecting with especially our kids about the true dangers of prescription drugs and prescription drug abuse and how it leads to heroin. For some reason, they don't necessarily relate to a guy in a tie. So what we did, again, bringing together a bunch of partners, is we produced a video, and it's called Equal Opportunity Destroyer. Because this problem truly is an equal opportunity destroyer. It doesn't matter which side of the tracks you're from. It doesn't matter your race, creed, gender. Doesn't matter your station in life. It affects you. What this does, what this video does, is examine in very real-world ways the very real consequences of prescription drug abuse and how it leads to heroin. It's about 15 minutes long, and I mention it because I want to share it. I want people to share it. It's available at eodwv.com. It's available at facebook.com/eodwv, at our Safe Schools website, at wvsafeschools.org. We're trying to push it out in as many fora as possible to really get some traction on this. I've got a few of the DVDs with me tonight, and if you'd like one, my email address is booth.goodwin@usdoj.gov, and I will be happy to send it to you. Another thing, as has been highlighted, our prescription drug monitoring program here in this state, I think, is remarkable. And Dave Potters, Mike Goff here with the Board of Pharmacy, they've done wonderful work in making that happen. On the prevention end of things, the governor instituted a task force that has been a traveling roadshow, and Kathy Paxton, Vicki, they've been out spreading the word and making sure that people know that there truly are prevention resources here in the state of West Virginia. And finally, on the issue of disposal, West Virginians have come out in droves and disposed of literally tons of prescription drugs during our National Take Back Days. But also what we've started to see is more stationary boxes at law enforcement agencies throughout the state, especially here in the Southern District. So much so that it did strike us that we needed a more systematic way of safely disposing of these drugs. And as a result, the Division of Justice and Community Services gave a grant that actually came from a forfeiture from the makers of OxyContin to fund 4 mobile incinerators to take care of all the drugs that we're taking back. The state police graciously agreed to house those items, but it's important to note that they're available for all law enforcement or community groups that need to dispose appropriately of these prescription drugs, because I think as a real result of those efforts and that 4-part strategy, 5-part strategy, we really have seen a drastic reduction in pills here in West Virginia. Of course, that has meant a resurgence of heroin, but from a law enforcement perspective, we've fought heroin before and we've beaten it back. And if you have heroin, it's illegal, and we can take care of that. It's a lot more difficult in the prescription drug realm when we're dealing with legal drugs. And last time I checked, heroin was still illegal in all 50 states. So I want to thank you all for coming tonight. I want to thank this distinguished panel for coming here and being with us. And thank you, Congressman Rahal, for putting together this very important work.
Thank you, Booth, and thanks to all of our panel. We have a message to deliver to our distinguished panelists, and there are none better suited, maybe because they're not in suit and tie, Booth, than some of the individuals who are in the audience this evening and on the front lines in the battle in southern West Virginia. The first, well, I guess he's out of uniform, so he is in a suit and tie, but the first I'm going to call upon is Captain Tim Bledsoe, West Virginia State Police Troop Commander, Bureau of Criminal Investigation, who will provide our statewide law enforcement perspective. Tim, welcome. Thank you for being with us.
Thank you, Congressman. Also thank all our panelists for being here this evening, taking time out to come to West Virginia. I think the first time that I was asked to speak in a setting like this, we also gave Mr. Goodwin an award. So you can relax, Booth. I don't have anything for you. The prescription pill to heroin transition is being felt statewide in West Virginia. Often, we have very limited state and county resources, and based on my experience, without the Appalachia HIDTA, I honestly believe that there will be very little organized drug enforcement in West Virginia. And what enforcement existed would be overall ineffective in making any type of a significant impact. We'd basically be a ragtag organization jumping around from stone to stone, chasing a monster that we probably couldn't catch. The tremendous success that we've had in prosecuting our pill mills and the doctors responsible would not have been possible without the Appalachia HIDTA and HIDTA support from the United States Attorney's Office. It would not have been possible for us to disrupt and dismantle drug trafficking organizations, bringing pills and heroin to West Virginia from places like Florida, Detroit, and Chicago without the resources available through Appalachia HIDTA. The leadership in place at Appalachia HIDTA is clearly the reason it's successful. It has been a successful operation. The director and deputy directors are the most professional and committed leaders that you could ask for. You need only look at the successes in the regions of West Virginia that are supported by Appalachia HIDTA, Appalachia HIDTA funded task forces to see the proof of how essential that HIDTA is to us here in West Virginia and what an impact it can bring to a region. So when you combine this with the additional support that we receive through the Justice Assistance Grant and the U.S. Attorney's Office, our officers are able to have more of the resources they need to provide our citizens with the enforcement efforts that they deserve. Please take away from this a constant assurance that financial support given to West Virginia through Appalachia HIDA is being utilized to the maximum potential. Resources provided to us do not simply go into a black hole to not impact our communities. And the reason is the constant evaluation of drug threats and drug trends in West Virginia and the surrounding Appalachia region, and the movements or presence of drug trafficking organizations here. These are things that Appalachia HIDA demands from its participants, and it yields impressive results for our state. There's no reason or no sense of entitlement for a county or a region to remain HIDA designated once that designation is obtained. And all Appalachia HIDA participants are readily aware of this fact. I have been continually impressed by this evaluation, both as a Drug Task Force commander and now as the captain of the West Virginia State Police Bureau of Criminal Investigations. And I've been impressed by the leadership for closely monitoring this process and how professionally that funding is managed by HIDA to make every effort to directly address the most current and real drug threats that our citizens face. A perfect example of the immediate impact felt by bringing HIDA designation to an area, we need only to look at our newest Appalachia HIDA supported task force based right here in Beckley. That task force is running strong and bringing much needed enforcement efforts to this area. The key to all this success is that HIDA funding brings us all together. We're all working toward the same goal, to disrupt and dismantle organizations and individuals that transport and distribute drugs in West Virginia. And finally, let me say that our efforts are not solely limited to enforcement. Education of our youth about the dangers of drugs and drug abuse is a must if we are ever to hope to see a major change in our state's drug problem. Education efforts are becoming more and more of a priority for our officers as their time and resources permit. I believe it is part of our duty to do our very best to provide our youth with the most current and specific drug threat information, while also providing that same information to parents, guardians, and teachers. Again, it is something that requires us to all work together for a common goal, which is our kids. And being a father myself, I can totally relate to that. There's nothing more important right now than educating our youth about the dangers that can be found, like we've discussed here this evening, in prescription pills and what that can lead to. There's not a more worthwhile common goal that we can all achieve. And we as law enforcement have to be at the forefront of the education effort. So thank everyone for being here. Again, thank you for supporting us on this issue.
Thank you, Captain. The chairperson. The chairperson of our Governor's Advisory Council on Substance Abuse is with us tonight, Commissioner Vicki Jones. Vicki, welcome. Thank you for taking the time to be with us and all your efforts as well.
Good evening, everyone. Congressman Ray Hall, thank you very much for hosting this event, and members of the panel, thank you so much. Welcome to West Virginia. We've got a lot of working relationships that already exist, and I look forward to many more. We've talked a little bit about statistics, West Virginia statistics. They speak very loudly. I don't think that we need to go over those again. But what I would like to go over is a little bit of the successes that we have experienced, because oftentimes I really don't think that that speaks as loudly as what we hear and continue to hear in terms of the epidemic that, quite frankly, we face. I am the chair for the Governor's Advisory Council on Substance Abuse, commonly and affectionately called the GACSA. And I'm also the commissioner for the Bureau for Behavioral Health and Health Facilities, within the Department of Health and Human Resources. The council was established by Governor Tomlin in 2011, and along with that, there were the task forces that we've talked about here this evening, and that many of you actually attend on a regular basis. And so let me thank you for being a part of the solutions that we have all worked together to achieve. The Governor's Advisory Council on Substance Abuse has a variety of individuals, from physicians, law enforcement, education, many others. The regional task forces, we have had 78 meetings. And when I talk about 78 meetings, I'm talking about in every region of the state. There have been over 4,000 individuals that have been a part of this task force and creating recommendations that have gone up to the Governor's Advisory Council on Substance Abuse, which in turn has reached the governor and our legislators, which has enabled us to not only obtain additional funding for substance abuse services, but it has helped and been a part of the legislation that has actually been created that we've all talked about this evening. We have provided guidance and continue to provide guidance on this very issue, and we continue to meet at the task forces across the state, as well as the Advisory Council on Substance Abuse. Sometimes we, and I'm really talking about all of us, we spend a great deal of time talking about these issues and actually doing something about these issues is what we're all here for this evening, and I think what we've all come to hear about and that we all hope makes a difference for tomorrow for us. And as we work through this, I think one of the things that we all are faced with is that balance of concern with hope that we are all looking for. I understand that there's so much more to do, that there is no silver bullet, but I also understand that we have achieved so much here in West Virginia that, quite frankly, 5 years ago, 10 years ago, we could not even have begun to imagine the success that we've seen. And I will tell you that this has all taken place and has been successful because of the collaborative efforts from the top down, from many of you, and the bottom up. This has been a common goal with solutions that we have worked together to achieve. We've talked about some of the comprehensive legislation that has been passed, and it required best practices for prescribing education for our healthcare professionals. We've tightened our requirements for our pain clinics and our opioid treatment centers, and we've provided $7.5 million in new, not realigned, substance abuse services funding. We know that working together as a state and regional levels really make a difference for us. In addition to this, we have funded 4 moms and babies recovery projects across West Virginia. And there's a statewide team that is led by Dr. Ira Chasnoff, and many of you know him. He's a leading expert in substance abuse in pregnancy. And it's comprised of physicians, nurses, behavioral health providers, insurance providers, and so many others, key leaders that have come together to promote consistent interventions with mom and baby. And we know that this evidence-based practice will reap better results for all of us. There's now drug take-back events, expansion of substance abuse prevention, and youth-led initiatives like the Wyoming County SAD chapter in all 55 counties. Recent national data show that for the first year since 2008, and this is a statistic that is astonishing because of all of the statistics we here in West Virginia face, but there has been a decrease in prescription drug misuse among those aged 12 or older here in West Virginia, the first time since 2008. That's pretty astonishing given the rise that we are experiencing in each of these areas just all by itself. We know that these community coalitions and task forces do make a difference. Community norms training is being provided across the state, focusing on the good and demonstrating the power of community voices. According to the West Virginia Poison Control Center, West Virginia has also seen a decline in overdose deaths from bath salts, which is, as you probably are aware, a synthetic drug. Environmental strategies can also make a difference. A prescription drug abuse quit line and behavioral health crisis lines, which help prevent users or individuals seeking to help a loved one, are available. And this increased referral and outreach service will improve our service navigation. Screening, brief intervention, and referral to treatment, commonly referred to as SBIRT, in multiple settings has proven that engaging earlier in the lives of our citizens is critical and will make a difference in treatment outcomes. Prevention organizations, we've talked a little bit about that this evening, are working with adolescent treatment providers in a cross-continuum planning effort to better structure service provision for youth and young adults with behavioral health needs. And when we do this, we're offering closer to home services at the right place and at the right time, and that will meet the needs of our families. The Department of Military Affairs and Public Safety and the Department of Health and Human Resources is working hard in a collaborative manner to reduce prison overcrowding and recidivism by providing effective treatment for substance abuse dependent or addicted individuals. And we're doing so in a collaborative effort so as not to duplicate the system of care that already exists. And by avoiding this duplication of services and shared systems, it will help us to expand our abilities to provide services to those that need these on a daily basis. The expanded funding and promotion of recovery coaching and recovery residents not only legitimize the best practice, but also reduces stigma by creating a job market for individuals with lived experience to share their knowledge and expertise, making a sustained difference in their lives of those in recovery. I believe that recovery, that people are coming together at all levels to make a difference. I think it's evident by those here this evening and each of you here this evening. And as a community and as a state, we are moving from really a helplessness and a hopelessness to what we believe to be empowerment and action. And that hasn't happened here for a long time, and I think we're on a positive path to achieve success. I would like to thank everyone again for your dedicated efforts, the collaboration and support that we continuously see and experience both at the federal level, at the state level, in helping each of us to really improve the system of care here in West Virginia. So thank you very much.
Thank you, Vic. From Mercer County, our next panelist is Judge Omar Abelhausen, who is West Virginia's 9th Judicial Circuit Court and one of the true leaders in drug courts in our state. Judge, we welcome you. Thank you for being with us.
Thank you, Congressman, for inviting me to be part of this. Booth, if you think you feel out of place, you ought to feel how I feel right now. I really feel out of place here to be amongst all these distinguished individuals here. I appreciate the opportunity to be here to speak. We do have a drug court in Mercer County. We were the second county in the state to start our drug court, and that was back in 2006. And since that time, we've had 243 participants in our drug court program. We've had 76 graduate from that program in that period of time. And we've had, out of our graduates, we've had about a 30% recidivism rate, which sounds a little high, but you go back to that first year when 3 out of our 4 of our graduates recidivated, and that was because I think we were just learning how to do this. Till you go to last year's graduates, and we have 10 graduate. 9 of those 10 are still successful, haven't reoffended, and those, when they graduated last year, 10 out of 10 were tax-paying citizens of Mercer County. And 3 or 4 of those were actually self-employed, started a business and created a business while they were participating in drug court. And so anytime we can take a drug-addicted individual and they come through the court system and we can put them back out in the court system and they become taxpayers, I think everyone in this room is glad to have taxpayers. I know as judges we are, because we want them to pay taxes to the state so we can get a pay raise someday, So our drug courts are working, and that's on the treatment side of things. On the prevention side of things, if I could talk about what we need and what I see, the vast majority in our state police are here can tell you that the vast majority of what they do is drug addiction problems, drug abuse, drug dealing, crimes related to drug addiction. 80% of the folks that come through my courtroom never graduated high school. 80% of our jail population never graduated high school. 16% graduated high school but didn't go any further. 3.5% graduated high school and went on to college or trade school but didn't graduate college or trade school. And then 0.5% of our jail population graduated college or trade school. So education is the key. And so we started a truancy program in Mercer County, and there are 9 or 10 other counties in West Virginia that have done that as well. And our logic behind that is if we can keep these kids in school, we can prevent them from becoming part of the criminal justice system. And if I know that 80 or 90% of the cases I have in my court are related to drug abuse, then if I have 80% of the folks not graduate, that have truancy issues, not graduate high school, then I'm going to, if I can keep them in school, I can reduce those numbers down, keep them off of drugs, because if they're not in school, they're out there on the streets, they're hanging around the wrong people, and they're going to have drug addiction problems. And so if I had to say what I think we can use in Mercer County as far as from the judicial perspective is we need treatment facilities. We don't have enough of those, and it's hard to get in. There's a wait list. 28-day facilities, while they're wonderful to dry them up for a little bit, does not cure drug addiction. It takes long-term drug rehabilitation. Our faith-based programs work fantastic, because I think it's kind of like a microwave that changes you from the inside out. So while I don't mandate people to go to faith-based, but if there's one available and I say, hey, here's one available, take your choice, you can do that or stay in jail or whatever. You got your choices. But if the faith-based helps, but there's also non-faith-based ones that can help, but they have to be long-term, and we just don't have enough of those. We are drowning with the lack of opportunity to send folks to drug rehab. There's a difference, in my opinion, as a judge, from being a drug dealer and you come to my courtroom and you have to face punishment, versus a drug user who commits other offenses in supporting the drug habits. And it's invariably stealing from your family members, from the people that care about you and love you the most. But if I can have resources to deal with that, if I could have resources to deal with the truancy problem that we have in Mercer County. When we started our truancy program, it was almost 5 out of every 10 students, 1 out of every 2 students were truant. Missed more than 5 days unexcused absence, and it's really worse than that. Most of the cases we get in our courtroom now, we're talking 15, 20, 30 days of absence out of a 180-day school calendar. And so it's a chronic problem. And when you think Mercer County has almost 10,000 students, and when you have almost 5,000 of those students being truant, that's a huge problem. We probably had 300 new truancy cases filed in 2013 alone. So far this year, we've had well over 150 new cases filed in calendar year 2014. So we're trying to tackle that problem, but really, we need to tackle it before it ever gets to court. And that takes more resources up front. That takes more coordinated services. We could use, for example, and I got 5 minutes, but we could use psychologists in our schools. We could use social workers in our schools to help deal with these problems before they ever get to court. And then the worst of the worst ones would be coming into court, and we could deal with those. But right now, we're dealing with all kinds of issues. And when you talk about truancy, you're talking about a lifetime full of issues that you're trying to cure in one case. Invariably, we're talking about kids who live in homes where they're drug addicts, their parents are drug addicts. No one gets up and goes to work. We're dealing with kids who have drug addiction problems themselves. One of the first cases I had as a judge was a 6th grader who was his drug dealer at his middle school. I was stunned when I was, back in 2009 when I got sworn in. That was one of the first cases I had. I had a 6th grader at home. I was ready to call the police and bring the drugs dog and, start searching the house. But it's scary when you realize it's that young. And I believe now it's in our intermediate schools, in some of our schools. And so, and that's because that's the leadership they have at their home. And we're having to deal with all those issues. And so, I appreciate all the efforts that are being done here. But in my view, on the front line, we don't have enough resources to deal with the drug addiction, those who are already addicted, to try and find treatment facilities, and then we don't have enough resources in trying to prevent kids. As Mr. Goodman, I've used that same line, it's equal opportunity destroyer. I've used that before you ever produced a video, so I'm glad you made a video out of it. But I've used that. I go to schools and talk to kids about these things. I give examples of them. I throw up pictures and I've got a set of pictures in my courtroom that I show people. Here's what drug addiction does to you. And it's the first time they're arrested, and then the next time they're arrested, or the 10th time they're arrested. And you see the difference in their face and how it just ruins their looks, and it kills them young. And I tell them all these things. And I go to schools and tell them, and I go to youth groups and tell them. And, we do try and educate our youth in that regard, but if we can keep them in school, we can avoid them becoming part of the criminal justice system, which almost invariably they're involved in the criminal justice system because of drug addiction, because they dropped out of school, because they weren't going to school. And I can go on and on and on about this. But I appreciate the opportunity to be here. I will close with that the number of 137 out of 100 that someone told us out here that's a big problem. I mean, the prescription drug problem is a big problem. We're now seeing meth in Mercer County, which we hadn't seen before this year, but it's there. It started this year. We've had a couple, 3 families kids having to be taken out of homes, abuse and neglect cases arising from it, criminal charges. We're now seeing that in Mercer County, and as a parent, scares the bejesus out of me. So I appreciate all the efforts here. I think I've said my piece. I think you understand where I'm coming from. So I appreciate you.
Thank you, Judge. Thank you, Judge. We appreciate your efforts as well. Mark Drennan is the Executive Director of West Virginia Behavioral Healthcare Providers Association. Welcome, Mark, and thank you for being with us.
Thank you, Congressman, and distinguished panelists. Appreciate the opportunity to be here today. I represent the West Virginia Behavioral Healthcare Providers Association. We have 25 members, and we have two of those members here tonight that represent this region. I'd like to recognize them right away, but that's Guy Hensley, and Guy's back there. He was with Seneca Health Services in Summersville, and Judy Akers, who's with Southern Highlands down in Mercer County and Princeton. So they're one of our great partners. Collectively, our members serve 100,000 people a year in West Virginia. About 65,000 of those individuals have mental illness, and about 6,000 of those are folks with intellectual and developmental disabilities. We provide addictions treatment to about 15,000 people in West Virginia, and there's about 14,000 West Virginians employed by those 25 entities. We like to say if we were all one entity, we'd be the #1 employer in West Virginia. But I know there's other people that can take that claim. We work really closely with the Bureau for Behavioral Health, and as far as Governor Tomlin's substance abuse task forces, our comprehensive members, which are 13 of our members, have hosted those task forces all across the state and have been great participants in that. There's been a lot of work done, and as Commissioner Jones said, we've made a lot of great progress. And I knew she was going to be speaking, so I didn't want to steal her thunder or have to follow her with the same things. But there's a lot of work that's left to be done. I took the time to reach out and talk to the members of our Substance Abuse Committee, which is really strong. As we said, we serve 15,000 people with addictions. So I asked the people who were on the front lines, told them I was going to be giving this talk, and I asked them, what to say. And each of them were silent at first because they are on the front lines and they see it every day. And I think the judge was saying that they're doing the work, but it just keeps coming, and there's never a break. And so I thought I'd put together recommendations from them as far as what we think that we can do. The first thing they said was we need to reduce the demand for drugs, whether they're prescription drugs, whether it's methamphetamines or marijuana or heroin. We have to do that. And I think Mr. Botticelli, I think you said it to begin with, is the way we're going to do that is through leadership. It's going to take leadership in Washington and in Charleston and in the county seats and the cities, and at home in our communities, in our faith-based groups, and in our schools. We need strong leaders. We need those leaders to set the tone for healthy and meaningful lives that will lead to economic development in West Virginia. You know, that's one thing we probably haven't talked about, but certainly we have issues related to lapses in our economy right now. We have folks that find it difficult to find work and to be employed, and a lot of these individuals who may be seeking employment have drug charges because they've been involved with the criminal justice system through the use of substances. We need leadership from doctors, and I think this is the key. We need our doctors to be strong. When somebody goes in to seek a prescription, a lot of times our doctors, my brother-in-law's a doctor, so I would tell him this too, are weak, and they go ahead and prescribe the prescriptions because the patient desires them. I've seen that change, though. I've seen that change my own primary care physician, who probably saw himself getting a lot of people who were pain-seeking. And I sat there one day as I was in the room, listened to him tell another, one of the patients, the walls were thin. It wasn't HIPAA, I don't think, but the walls were thin. And that he wasn't going to prescribe them any medications. And here's where you can go and get help. And I don't know if someone talked to him. I don't know if his name came up on a list that you've prescribed X amount of prescriptions above and beyond, but he changed, and I saw a change in him. Secondly, and I think Vicki touched on this a little bit too, is that we have to foster hope. There has to be hope in the lives of the people and the families who are touched by addiction. And this is something that comes from me. If we're going to expect a new era of prosperity in West Virginia and other areas that are affected by drugs, we need to clean our house. And that means that, and I think government can facilitate, I mean physical cleaning. If you go through some of our neighborhoods and some of our communities, we just need to pick up. You know, that's stressful in itself, and it's stressful for communities. It's stressful for kids who look at that every day and they say, what do I have? You know, I just got this. But if everybody pitched in and we start picking up the things, I'm reminded of A. James Manchin, who went around and picked up all the junk cars back in the 70s. It's something similar to that project. But I think that some of these old sayings, they keep coming back to me because we get back to the basics of this cleanliness next to godliness. And I don't think it has anything to do with religion as much as it has to do with it helps us get to where we need to be. I know there's law enforcement here, and I'll preface this by saying that my brother, my only sibling, my best friend, is a 17-year veteran of the Kanawha County Sheriff's Department. But I think we need to take steps to reduce the criminalization of addiction. And today we have so many nonviolent criminals who are tying up our prison systems and our courts when they do, and they serve their time. I'm not against people serving their time and doing their punishment, but when it's done, it needs to be done. There needs to be a path, I don't know if that comes federally or in West Virginia, for expungement of some of these records. When people get clean and they get sober and they get back into society, let's let them back in. You know, when they've paid their time and they've done their due, then let's give them the path. You know, if you have a bankruptcy, if you're Donald Trump, you have a bankruptcy, 7 years, that's off your record. But if you got arrested for dealing pot and it was 30 years ago, you still go to your potential employer and you have to have a criminal background check, and that shows up. I personally have not hired people who have had drug charges or DUIs from 20 years ago, and we need to do something about that. Thirdly, we need to pay for addictions treatment, and we need to pay what the cost is. You know, many of our members are out there doing this every day, and the margins are so slim. It's so tough to bring the talented people to deliver the service in West Virginia and to keep those people because our pay sometimes is too low. So we need to really pay for that treatment. we need a completely funded continuum of services. And we've come a long way. I mean, Vicky's talked about the $7.5 million. Our members have applied for some of that, and there's been a lot of transition. And I heard some stress from our direct care worker, direct folks on the lines when I was speaking to them, because there has been such transitions. They don't know what's going next for them. What's the program going to look like next week because things are changing. Somebody said it's the best of times and the worst of times. It's the best of times because of the Affordable Care Act, because there's more people that are going to have access to treatment funding. It's the best time because there's $7.5 million that's been allocated by the governor. But it's the worst of times because we have so much work to do and because there's so much change that's going on. So, so the continuum is really important to keep that going, from therapy to medication management, peer recovery, to residential treatment, and all points in between. Also mentioned is the recognition of certified addictions counselors, on par with other individuals to provide those treatments. So Susie comes and talks to me about that on a regular basis. That's why she's clapping. In children's services, we need help for the entire family. And there's, you know, a lot of times we try to focus on that one individual, but this is a household problem. You know, I always talk about my brother, but I talk about my brother-in-law and my wife. My wife is a neonatal intensive care nurse, and she works at Cabell Huntington Hospital, and she sees these infants that come in that are drug exposed. And you know, we were 1 in 5, and I think we're approaching 1 in 4 in West Virginia. And we just can't let that be anymore. So we've got to treat the whole family. Another thing that was brought up by our members was we need to recognize addictions as a chronic and relapsable disease. And I think that we talked about that, you know, from Samsha and Doctor on the end. We don't recognize that as a chronic relapsable disease as a community and as a population. One thing is we need to reverse the trend of generalist practice, and they actually wanted a question, so I'll write this question for some of our panelists. I think it might be for Samsha, but wondering, there's a lot of generalist practice between mental health and substance abuse coming down the pike, and what they were saying is we need specialists that deal with addictions. While there's a lot of co-occurring disorders that take place, we need specialists. We need gurus in addiction services that can treat our crisis. And, you know what? The other one is we need to take advantage of the attention that's currently paid to this crisis. In West Virginia, we need to keep the focus on Governor Tomlin's substance abuse task forces and the Governor's Advisory Council. We need to provide leadership to community and faith-based groups that want to do something, because I see so many of those groups who see these people come through their churches and through their communities, and they say, what can we do? And they just don't know where to go. So we need to provide leadership to those folks too. And finally, we need to ensure that addictions providers like those in this region and in your district, Congressman, like Seneca and like Southern Highlands and FMRS, Logan Mingo and Prestera and others, that they have the resources, not just financially, but those are important as well, to adequately deliver the services for treatment and recovery. I'd like to tell some good things that are going on as well. Like you did say, you talk about some solutions and some of the things that are going on. Right here in this area, Southern Highlands just opened up 2 years ago, almost 2 years now, the Hartley Group Home. And through the Justice Reinvestment process, which we were involved with as an association, and BHHF was involved with, and others, is going to be opening up a new intensive outpatient program that's going to serve up to 24 patients per day at Southern Highlands. And they're also involved in a joint ventureship with the Healing Place of Huntington, which came from the Healing Place of Louisville, to serve between 60 and 70 individuals who are in recovery. FMRS, which is just one exit up, I think it's one exit, Kyle will tell me, and out to the right, has Turning Points for Women, which was sponsored by the Bureau for Behavioral Health that helps women who were seeking treatment for their addictions. And it's open within the last 2 years as well. Just a couple of weeks ago, I got to go down to Lewisburg, and Guy Hensley in Seneca just opened up the Crosswind Center in Lewisburg, and I understand he's been getting referrals for treating addictions in individuals who are in crisis with mental health. Together, the association has about 300 treatment beds statewide, and those beds stay full on a regular basis. The judges here, and a lot of times those beds, there's a waiting list. Sometimes those get tied up because they're court order placements, and I know the courts get frustrated because there's no place to put them, and they want to order the folks to go for treatment. And sometimes that process, if there's 80% of them, they're tied up, leaves 20% to turn over. But we're there to support the court system and the law enforcement with those beds, and I think there's a whole lot more that we can do. Somebody said it, I think, earlier, that treatment's not just about beds, but there's a lot of community-based services and in-home services that we can do that doesn't necessitate a bed. On the federal level, I'd just like to thank the Congressman for his support and the recent passage of the Excellence in Mental Health Act. I don't know if folks know this, but up until the passage of that act, there was actually no definition in the federal code for behavioral health, and this act actually, and the definitions in that code actually tie funding. And so by the passage of that act, it actually developed definitions for behavioral health services, and this legislation should cultivate a robust mental health and addictions treatment system by requiring qualified health centers to meet certain requirements, and then that'll direct a bundled per visit rate that's similar to what the FQHCs have now. So Congressman, thank you for your support in that. Just to kind of repeat a little bit about it was, in closing, we need to reduce the demand for substances through strong leadership. We need to foster hope in communities and families for recovery. We need to pay for treatment because treatment works, so we got to pay for that. We need to take advantage of the attention and act. I think Vicki's telling we are acting. We need to continue to act. And we need to ensure resources for West Virginia's network of addictions providers. So again, I want to thank the panel for the attention. Thanks for being C Booth's video, because if you don't shed a tear, then you better check your pulse. It's excellent, it's excellently done. Our website is wvbehavioralhealth.org. On our website, we have a service finder. If you know someone that needs addictions treatment in your area, you can punch in your zip code, and it'll give you the top 4 treatment providers within it, and the radius and the phone numbers that you can call just right there. And we're paying attention to it. We just revamped that website. We're doing a video on. We're producing. It's going to shoot on Friday a video for our website on addictions as well. One that's going to focus on hope. So, thank you, Congressman.
Great. Thank you, Mark. We're going to have 2 more presenters, and then I'm going to use the prerogative chair and go right through the break. We're not going to have any break. If anybody needs to take a break, you can take it on your own. If not, too bad. And then we're going to go straight to questions from the audience. So David Potter is the Executive Director of our West Virginia Board of Pharmacy, and we appreciate all your efforts in being a partner in this fight as well.
Congressman, members of the panel, thank you very much. The West Virginia Board of Pharmacy, so we're where all the pills come from, and it's our fault. And Booth, I do want you to know that plagiarism is alive and well, and I will be using the Sesame Street reference in the future. What does the Board of Pharmacy have to do with this situation? Well, we license the pharmacies, the pharmacists, the pharmacy technicians who are out there dispensing. We also license the manufacturers and wholesalers that bring the drugs into our state. But quite frankly, when I look at the issues, to me, it's what does the Board of Pharmacy do at an individual level? Because we can talk about supply side all day long, and we can talk about the demand side all day long. And when you get down to the bottom of each of them, it's an individual choice. It's an individual responsibility, completely, 100% all the way through the spectrum. If a doctor wants to prescribe a medication to somebody who does not need that medication for a legitimate medical purpose and it's a controlled substance, that doctor, who is an individual, just made that choice. If a pharmacist who has a concurrent duty under the law to ensure that a prescription drug medication prescription is for a legitimate medical purpose and buries their head in the sand that the person in front of them looks completely out of it, is coming from 2 states away, the doctor's from another state away, and dispenses it anyway, that pharmacist has just made an individual personal choice. The person that made that individual choice to seek that drug in the first place is the patient in the doctor shopping scenario. And I had an addictionist tell me one time, well, it's not their fault because their brain has been changed by their addiction. And my answer was their brain was not changed before they took the first pill. Now, maybe they took the first pill because they had an injury and it was a legitimate prescription and now they're addicted. Those are things that we can try to deal with. We can shrink the problem. We'll never get rid of the problem as long as there's depression, anxiety, schizophrenia, bipolar disorder. So long as all these things exist, we're going to have people that will self-medicate and seek out illegal substances. But we can shrink the problem and make it more manageable. So how does the Board of Pharmacy try to do that right now? Well, we advocate certain things like changes to the laws regarding controlled substances at the legislature. Some folks were not happy that the board advocated hydrocodone being moved to Schedule II, because if it were moved to Schedule II, then physician's assistants and nurse practitioners would no longer be permitted to prescribe it, and that would cut into the available supply. Well, that was the intent. That was the point, because 70% plus, SAMHSA tells us, of the prescription drugs that are diverted are not diverted by stealing from a pharmacy, robbing a truck on a delivery route. They're stolen, bought, or given away, or borrowed, or handed to, here, try one of mine, from the medicine cabinet at home. So if 70% of the drugs that are dispensed out there in the homes, if 70% of the diversion happens from those that are in the medicine cabinet, what can we do about it? Well, hydrocodone is our #1 dispensed controlled substance. So let's try to limit that supply. The will was not there to move it to Schedule II, so the compromise was to keep it in Schedule III, but limit it to a 30-day supply. No more than 2 refills, without the prescriber having to make a cognitive decision to issue another prescription. So no more than 30-day supply of hydrocodone is now available in the medicine cabinet thanks to this new statute. Whereas before, somebody could prescribe very easily a 60 and 90-day supply commonly, but nothing against the law if they wanted to prescribe a 6-month supply. Let's say somebody lives in Alaska and they can only get to the doctor once every 6 months. That may be a perfectly legitimate law for Alaska. I don't think that would work so well here in West Virginia. So there were compromises to be had. We advocated for 3 years that tramadol be made a controlled substance. For 3 years. In the 4th year, it finally made it there. Why? Because of some of the leadership at the federal level. The feds had finally pushed to make tramadol a controlled substance. We didn't know when it was going to become final. The legislature decided that, well, we'll go ahead and make the steps. So we beat you by a few months. But that was leadership on the federal level that helped push it over the hump. Marijuana. Is it a gateway drug? Law enforcement tells me yes. Medical marijuana. Is it appropriate? Many people will tell you yes. Many people will say no. So the Board of Pharmacy said with every other prescription drug that we have out there, the FDA has to test it and make sure, or review the testing, the studies, and make sure that it is a proper drug to be prescribed to our folks out here who need it. The FDA has made that decision with 2 drugs that contain cannabinoids, and those have been on the market for years. There's a drug in phase 3 testing, but until then, the Board of Pharmacy did not feel it would be proper to advocate for the legalization of medical marijuana. So the board suggested otherwise. And members of the legislature had to take up that bill this year, and I don't think that the Board of Pharmacy's advocacy pushed it over the top in defeating that by any means, but they did agree that we're not ready for it yet in West Virginia. And it is a gateway drug, whether you like it or not. No matter what your feelings are as a libertarian or whatever, I should be allowed to take what I want to help myself. Those are all free for debate, but like it or not, marijuana is a gateway drug. Unfortunately, coming up and maybe getting ready to surpass it has been the prescription drugs. So how do we get at that? Well, we've had PTs, pharmacy technicians, and pharmacists divert to self-use. We've had pharmacy technicians admit when we've taken their registration away and they've gone to jail thanks to law enforcement intervention, that they only got the job as a technician so that they could get access to controlled substances, so that they could sell them or give them to their boyfriend, girlfriend, husband, wife to sell to supplement their income. So that's a touch point that the Board of Pharmacy has. When we find one of our licensees that's involved in that activity, we have to move to try and remove them from the pharmacy, usually with law enforcement's help. We have the Controlled Substance Monitoring Program database, which is probably the only reason we were really invited here today, because that is our biggest touch point in the direct where the rubber meets the road in this issue. What is the Controlled Substance Monitoring Program or a prescription monitoring program? All it is a record in a central database of every dispensing of a controlled substance in West Virginia. We have over 5 million dispensings per year in that database. We have 1.85 million people in West Virginia. That means if you round it down to 5 million, every 3 months we have 1.25 million dispensings of a controlled substance. Number 1, hydrocodone. Number 2, Xanax or alprazolam. Number 3, but a relatively distant third, is oxycodone. Why is oxycodone a distant third now when it used to be our problem? Well, it is a Schedule II, whereas hydrocodone is a Schedule III, hence the reason for my earlier comments. But also there was a lot of focus put on it. Law enforcement cracked down. The Purdue Pharma asset forfeiture money was about what? It was about Purdue Pharma's marketing of OxyContin, oxycodone. So we can have an effect on the supply side. On the demand side, the prescribers have that responsibility if they use the monitoring program to look and see, is a patient receiving prescriptions from multiple other prescribers? And so we are driving every day increased use of the monitoring program. We have 685,000 reports run every 3 months out of the monitoring program. Most of those would be prescribers and dispensers. There's also law enforcement and licensing agencies using it. But 685,000 reports every 3 months. Now again, I mentioned we have 1.25 million dispensings every 3 months. Now a lot of those are refills. So, you know, it's not unreasonable. Maybe if somebody looked before every dispensing, they might choose otherwise if they're a responsible prescriber. Unfortunately, we have pill mill doctors that will call the office in times past, 2 of them that I can name very quickly. The office manager, Myra Miller, on behalf of her doctor, Dr. Schaefer, called me once every 3 or 4 months to make sure I knew that she was running the monitoring program reports on the patients of their pill mill. Why was she doing that? Prophylaxis. Wanted to give a good impression. So there are doctors out there who will lock you into a pain contract, and you're only allowed to go to me, and you're only allowed to go to this pharmacy, one pharmacy. So you won't see doctor shopping, and you won't see polypharmacy with these doctor shoppers necessarily, because they don't have to shop anymore. They've got their candy dealer all locked up, and the candy dealer's got them locked up because they want the cash, right? So it doesn't matter sometimes if the doctor even runs a monitoring program report. So like my parents told me a long time ago, locks are on the car doors and on the houses to keep the honest people honest, because we all get tempted from time to time to do something bad. And if I see something in the car that I want to break in and get, and I pull the handle and it doesn't open, then my conscience gets the better of me and I don't break the window and get it. The person that's going to be bad is going to do it anyway. So the monitoring program is not going to stop the pill mill doctors. The monitoring program may affect the supply available to the doctor shopper, to the patient. So what we're doing is with our review committee and through some algorithms and some parameters that the advisory committee to the monitoring program have established, we've sent out in December and January 2,200 letters, and in July another 3,000 letters to prescribers of patients who have gotten prescriptions from first 14 or more doctors in the prior 12 months, and then the second round 12 or more doctors in the prior 12 months. One patient in the first round had 31 different prescribers. That meant that one patient generated 30 letters, and each one of those doctors got a letter. In the second round, at 12 or more, we had a patient that had 32 prescribers. But we also saw the average numbers hopefully coming down a little bit, which is why we shrunk down to 12 this time. We're hoping someday we can send those letters at 8 or more. And it's not a letter to tell the doctor that your patient is a criminal. It's a letter to say, did you know that your patient has gotten prescriptions from 11 other prescribers besides you, 12 others besides you, et cetera. And then that prescriber can take into account whether or not they want to continue to prescribe to that patient, refer them to treatment, kick them out of practice. And unfortunately, the heroin rise in this country is twofold, in my opinion, from what I've been taught by law enforcement and from my own observations. And one is, as people do become addicted to the pills, then they turn to heroin. But also, we're pushing them, hopefully, quite frankly, hopefully, to heroin from the prescription pills if they're taking the prescription pills illegally. Because that means we are successfully reducing the availability of those pills to them. Along with the letters, we are also, to the prescribers, we're also starting to take a look at our top prescribers and top dispensers. And through the review committee, they're trying to see if they can tell from what they're looking at whether or not some of those need referred to their licensing boards or to law enforcement for them to do an investigation. We can only get a cursory glance based upon the monitoring program, and that's why it is a referral, not a decision. In the same way that the patient might be legitimately seeing 8, 9, 10 prescribers because of a group practice, in specialists, an emergency room, and so on and so forth, there might be reasons why these prescribers are the top prescribers. Maybe they're a specialist in cancer. Maybe they are a legitimate pain clinic, so on and so forth. So it is recommendations. But back to the individual responsibility, we also referred 125 patients that had the 12 or more prescribers to law enforcement. Now, law enforcement will look at those, and some of them will be arrested whenever they do their investigation, and some of them will be prosecuted. If we can stop the demand, we don't have to worry so much about the supply. One thing you will always see as a success in the free market, in a free marketplace, is the black market. Whether it's the old Soviet Union and blue jeans, Levi's from America, or whether it's drugs on the street. If there is demand, then somebody who wants to make a buck will meet that supply. You can arrest every single cartel head. You can arrest every single bigwig drug dealer in your neighborhood, so long as there's somebody else demanding and demanding and demanding for those drugs that keeps the price up high enough, there will be somebody willing to pocket the cash. And to give an example, one of the prosecutions I noted in the Southern District of West Virginia, the gentleman had, I don't know, over 30 guns, 2 houses, and I think it was $500,000 cash in his house, right? That was the property, the asset forfeiture from this drug dealer. How many other thugs do you think are out there that wouldn't like to have 2 houses, $500,000 cash, and a bunch of guns? So as soon as that person was arrested, because of the demand, somebody took their place. So I think that we need to get at the demand. And since I'm on the soapbox, I'll say that I have 3 kids that were last year 5th grade, 2nd grade, and kindergarten. When they go to school every day, they put their seatbelt on, without question. When I was a kid, I didn't wear a seatbelt. It's one generation. When I was a kid, all of my aunts and uncles smoked, and I thought it was cool. It was on TV, it was in the movies. My kids think that smoking is a stinky, nasty, dirty habit that wastes your money, makes your teeth yellow, stains your fingers, and causes health problems. If we have the same type of generation-long education prevention program with our children, starting in grade school, that we did with seat belts and smoking, we can start affecting the demand. But so long as we are, as a society, focused on counting how many marijuana plants we cut down yesterday and today, and we don't care to make the investment in the numbers that we won't see for a generation after we've left these positions and we can't take credit for them, then we aren't going to dent the problem. If we're focused on today and the numbers we can count today, how many millions of pounds we've disposed of, how many arrests we've made, how many dollars in asset forfeitures, then great. We need to do that today. But the investment has to be for a generation from now. Otherwise, we're wasting our time. Thank you.
Thank you, David. Very, very interesting. Our final panelist, before turning it over to the audience, is a gentleman from Mercer County that I've been working with for a number of years / decades, I guess now, and he's had quite a positive influence on our youth in southern West Virginia. That's Greg Puckett from Community Connections in Mercer County. Greg, welcome. Thank you for being with us.
Thank you. Well, good evening. I promised Diane that my remarks would be under 30 minutes, so we should be good. Congressman, on behalf of all of Southern West Virginia, thank you so much. Director Botticelli and all the rest of the panelists, thank you so much for coming to Southern West Virginia. I spoke, Dr. Sosa, one of your associates back there, she said she really enjoyed the trip down the turnpike. She said she didn't realize it was so windy around the curves. And I told her, I said, well, you're going to McDowell County and Wyoming County tomorrow. You ain't seen nothing yet. So
That's right. That's right.
you should be doing well. Also, if you would have only told me that we didn't have to wear a tie, I think I would have been fine. And lastly, Director Botticelli, you'd mentioned in the very beginning, there is no silver bullet, and you're 100% correct. Here in West Virginia, we've been doing a lot of prevention, positive norms trainings, and we've been going at things. And to reference a J. Otto reference from Montana State University, we're looking at this from a silver buckshot theory. That's a West Virginia cultural thing. So, but we're looking at it in terms of, we're going to shoot and we're going to shoot broad. Some things we may miss, but a lot of things we're going to hit. And I think that's kind of where we are within the state of West Virginia, is that we're hitting a lot of things. And you've heard the panelists this evening, and you've heard the successes, and yet also some of the challenges. My agency, Community Connections, has been working on this for a number of years, and we've seen a lot of those successes. But we still see the challenges. As a family resource network and some of the ways that we've collaborated with our community coalitions and our partners, we know the value of collaboration. And we also know the value of really getting everybody to the table. And we're hoping to continue that trend as we go forward. I know in our agency alone, even though that we're a family resource network for Mercer County, we're very diverse in some of the things, and we hold a different perspective in that there's things what we call prevention without borders. In that we know that it may not be an issue that directly affects us within our county or territory, but it adversely affects us in different ways because of our transportation infrastructure that we have in the southern part of the state. And you will see a lot of that as you make your trip down to the south. Within the Appalachian region, we're very unique in our culture. We're very isolated. We're very family-oriented. And with that comes a sense of pride and also sort of a sense of honor. But it's also that sense of giving back and taking care of your own that kind of haunts us in some ways. We want to help others, and so we frequently give prescriptions to our family members and our neighbors, even though it's not legal to do so. And so we really need to affect the supply of what we have on the streets, and a lot of those pieces I think we're doing. In our southern region, we possess the highest morbidity rate in the state, in the region you're in right now. And has already been described in the comments earlier, we're already the highest in the nation. So you're sitting in the highest of the highest right here in southern West Virginia. In Mercer County, where I'm from, per capita, we have the highest rate of hepatitis B and hepatitis C in the nation. And our HIV rates are skyrocketing because of our disproportionate use to African American populations. And we know that. Our neighboring counties are suffering from unimaginable poverty and neglect, and pills are not just seen as a way of coping, but as I mentioned to you in April, they're actually a way of trade. They're a way of paying for goods and services in a lot of our counties, and they're using that in ways that it was never imagined to be used. Drugs, well, the pharmacist that I use says that hydrocodone, as is mentioned here, is the drug of choice, and that he's filled more prescriptions in the last 6 months than he's filled in the last 3 years. So we've got to do something about that. We worry, as I mentioned also in April, about the new drugs, Ohydro, that when that hits the streets, we frequently call that, that's OxyContin on OxyContin. That's just how bad that's going to be. And so we are worried about that, and we're already worried about the new things that are coming down. What's that going to do to a family? Well, to be honest, how do you tell a 5-year-old child that mama's feel-good medicine is a bad thing when this is how they're being raised? How do you change a community when a generation lost is turning and it seems completely hopeless? And like the disease that it really is, we see this spreading. For many years, and you look at an economic development perspective on this, we've been seen as a community that works hard and is really striving for better things. But in this last generation, over the last 10 years, we've been perceived as disheartened, unforgiving, and sometimes, even by our employer's standpoint, lazy. That's not who we are. We're West Virginians, and we're better than that. However, with that across the state, there is plenty of hope, and we've talked about that tonight. As one of the family resource networks and other community coalitions that are existing within the state, you know, we work with the DEA Take Back Days, and we've done a lot. We've actually taken some of the substance abuse block grant funds, and we've leveraged those funds to put some permanent take-back sites in our courthouses, and we're doing it the best we can to get those drugs back off. And to have the mobile incinerators is, to be honest with you, that's wonderful, because that's something we've needed for a very long time. Oftentimes what our law enforcement agencies do is they bring those drugs in and they hold them for the take-back days. And so in that sense, it becomes a risk that we just simply can't take anymore. We can't hold them for 6 more months. So thank you. In working with several of the other partners that we've seen, you know, there are 7 drug-free communities grants currently within the state of West Virginia. We are one of the drug-free communities grants that has aged out of that system. It's been very beneficial for us, and we've used all those funds to leverage each dollar forward. And we've worked with other communities across borders to make sure that they're going to be ready, that their community coalitions are capable at really making community-based change happen. And I think that's been great. More good news. The Bureau for Behavioral Health, as mentioned earlier, is working more than ever to effectively leverage the block grant funds into really doing everything across the continuum. That's prevention, early intervention, treatment, and recovery. And, you know, Director Botticelli, you saw that firsthand during the Integrated Behavioral Health Conference, you know, last year. So thank you very much for coming again. With the expansion of prevention programs and what is the new Partnerships for Success grant through SAMHSA, there are 12 communities throughout the state of West Virginia that are going to receive special prevention-based funding. They're going to be focused on 2 core issues. Number 1 is underage drinking. There's going to be 6 counties across the state focused on that. Within our region, you're going to be in McDowell County. And also on prescription drugs, which is Wyoming County. And those are going to be focused on that. Within that, our agency is working with the Bureau to create what's called Prevention First communities. We want to highlight the good stuff that's going on in the state of West Virginia. We're tired of dealing with the negative. We're tired of looking at statistics in the way that we see them. And we know that there's a lot more positives out there, and we can make change happen if we work together. So that's what we're going to focus on. This Prevention First norm change, this positive norms piece, is really going to be focusing on all of those good things happening. And we're going to treat it like the pedestal theory. We're going to put people so high up on a pedestal that they're going to be so scared to fall off that they're going to be able to hang on up here, and we're going to make others strive to be like them. Not looking at the negative and wondering if you're going to end up like that. It's 2 different ways of looking at it. As a lifetime West Virginian, I can tell you that the willingness of our people here in southern West Virginia is second to none. We want our communities to be better, not just for our lives, but for the lives of others around us. And although our resources are somewhat limited on a lot of scale, you know, we're working hard to sow the seeds of prevention that are going to last for generations to come. The last thing I want to tell you is you're in coal territory. And if there's one thing that we know about coal is that with great pressure can also come diamonds. And I will say that the diamonds back here, the t-shirts, those are your diamonds. That's the 2nd rated SAD chapter in the United States from Wyoming County, West Virginia. You're going to be visiting their teen center tomorrow, and I think you will be thoroughly impressed. And if we had tons more kids like that, you're going to see the lives of everybody in West Virginia change for the better. Thank you.
Thank you, Greg. I'm glad you recognized our SAD chapter, Greg, because I was going to do that before moving to the audience for questions, which are now getting ready to do. No, I'm glad you did. And I want to ask any of them if they want to stand up and say something. Please. I know this wasn't planned, but it's the floor is open to you. Okay. Well, we'll be seeing you tomorrow because we will be traveling through coal country, Greg, in the morning, starting out at Welch and then going to Pineville. It's our Coalfields tour. We're going to be at the Southern Highlands Community Health Center at 9 a.m. in Welch, and then we're going to the Wyoming County Teen Center in Pineville. We're going to the FMRS back here in Beckley. So we've got a long day tomorrow, Mike, and I want to open it up now. Did we have questions submitted or whatever? But anyway, whether we had them or not, the floor is open to the audience.
Yeah, and in keeping with the positive spin, we've seen some technology, maybe from Dr. or Mr. Bonicelli from a standpoint of policy. There are companies, and Mr. Potter's touched on how OxyContin has declined. And one of the reasons that I understand from talking to law enforcement is they've come up with tamper-resistant products. And so you've seen that be effective. And also now with talking about Mercer County's now hitting with methamphetamine, pseudoephedrine, the states that have passed prescription-only laws have reduced their labs from hundreds to 10. And now we have tamper or conversion-resistant products with pseudoephedrine. Why aren't we encouraging the development of this technology, which has been shown to be effective? I mean, people are going to follow the money. The companies, if there's R&D to be done, and it's shown to be effective with OxyContin, and we've now got products, these tamper-resistant products should be where we focus. Pseudoephedrine, if it's not tamper-resistant, should be prescription only, or not available.
If you look at our prescription drug abuse plan, calling for tamper-resistant medication and development through the FDA has always been an important role in terms of what we're doing. And I think we've also seen the FDA look at increased labeling standards in terms of the warnings of those medications, as well as requiring risk mitigation strategy and education for physicians for some of these medications. One of the things I do want to mention, because folks raised this OHydro issue, and I think it's important to talk about, is that we're really closely monitoring this OHydro issue through our prescription drug monitoring programs. And it looks as if at this point the prescriptions are very, very low for OHydro, and I think a lot of physicians are understanding that. I think actually state pharmacy benefits managers are not putting OHydro on the formulary, so we've seen very low utilization on it. But the other piece, and I think folks have recognized this, is yes, we need to make sure that we diminish the supply and that we have tamper-resistant issues. But having been doing this work for a long time, there will always be a substance of abuse, right? And so one of the issues that we see, I think, in terms of the heroin transition is, again, I think we need to study more, but part of it is supply related. And so this is where things like the Commissioner talked about today, where screening and brief intervention, making sure that our people who are cutting people off from supply are referring them to treatment so that we're diminishing the chances that people progress to heroin. We have to look at every opportunity as an intervention point. So this is where, to your point, continuing to develop and improve tamper-resistant medication is important at the federal level, as well as a whole host of other strategies.
Well, thanks for setting up this. I've been in this field for 40 years. I'm a little cynical of some of the things which you all are suggesting, because I've worked in England, I've worked in Canada and here. The biggest problem I see right now is the supply side. Demand, like the pharmacist said, is good, it'll take a long time. But the supply side has come down. And the only way supply side can come down is the greed on the part of the suppliers, physicians and pharmacists. Unless we get the cash out of the system, this will. Beckley itself has 8 pain clinics now, and leave alone the physicians who are prescribing. When they open a clinic, charge the patient cash, and give the prescription, and they are filled by the various company. Unless we do something about cash, this is not going to go down, period. Where it's a chronic disease, like Dr. Walker said, that there are no drugs, there won't be any addiction. For example, methadone, all right? It doesn't come on the pharmacy profile because there's a federal rule, and that's a silly thing. Or for example, they started with drug monitoring, all right? For example, we can write any drug we can write and send it to the pharmacist, but the minor tranquilizer we have to give to the patient, and those patients You call them, they go there, they don't pick up the prescription, but they pick up their mind tranquilizer. I mean, these rules are something which is absolutely out of the norm. All right? And I think I'm just saying, for example, methadone. Now, we need to open a methadone detox clinic. 50% of the patients in methadone want to get out of methadone. But the CRC, which made $450 million last year, don't want to give it up because they want the cash. So they need to open a methadone detox clinic to be run by not-for-profit. And there are some suggestions if you can look into that. But the main thing is, as I said, cash on the part of the physicians, pharmacists, everyone. For example, I went to a conference last year, 2 years ago in Florida, and the pain clinic had been taken over by the drug cartel. All right, and they were paying physicians $500 an hour to go and write to the pain clinic. And I'm just saying, so the federal government actually, when Suboxone came in 5 years ago, I told, and I don't think I'm captive there, I told them that unless you get the trained physician to do it, and you open it Tom, Dick, and Harry because there are not enough providers, you will create a problem, and that is what happened. Suboxone in the street, it becomes a big problem, and every orthopedics are writing it, even in this area, orthopedics, gynecology, they're more semi-retired and don't think it's Suboxone clinic. Cash. So I thought just make my own 2 cents worth in that regard.
Anybody on the panel with comment? Good, Doctor. Susie?
Well, piggybacking on the message of hope, and I want to kind of switch a little bit of focus and just make a couple of announcements about hope and recovery in West Virginia. I work for a company based out of Charleston called First Choice. My program is technology assisted care through one of the SAMHSA TAC grants. And we have several events planned in West Virginia that we'd like to extend an invitation to everybody to attend in celebration and recognition of recovery and what recovery people contribute, what happens when people get into recovery. And I agree with a lot of the things that were said, and especially the expungement and not making this a life sentence. The judge spoke about people who started their own business. Well, they have to start their own business because nobody else will hire them. So, those are the barriers that we have to remove. And so if we look at people who are in recovery and look at all the possibilities. So we have been showing the anonymous people around the state. We've been providing these T-shirts about recovery. We have Recovery Day at our ballpark in Charleston, Power Park on August 31st for everybody and anybody to attend to celebrate recovery and bring some attention to recovery. If there's anybody in recovery who'd like to come throw out the first pitch, we're looking for somebody who can make the ball go all the way. We have quite a few people, but we don't know that they can quite get the ball all the way. We are having an event called Championing Recovery at the legislature September 9th, and we want people, if you've seen the film The Anonymous People, it talks about the history of recovery and how the recovery movement basically got driven underground. And we want to get, 2.0 going here and get the recovery community back into the spotlight. And for any of you who ride motorcycles, Congressman Ray Hall came and surprised us last year in Point Pleasant at one of our pit stops, but we will be kicking off from Huntington this year on Saturday, September 13th, that morning with a breakfast. So if you ride motorcycles or just want to watch people ride motorcycles, follow us in your car. We're going to go from Huntington to Point Pleasant and end up in Ripley. So we try to focus on a few different communities every year to bring attention and celebrate recovery. The question that I have related to technology and recovery, we actually this morning started the day out in Parkersburg where our program was recorded and our clients were recorded for SAMHSA Road to Recovery television show. So that will be aired in September. And we visited 2 sites and were given feedback by clients and staff about our project. And one project was the Genesis program at Westbrook, Women's Treatment Recovery Program. And the other program was the Wood County Day Report. And so we use the HS app and technology and smartphones. And so we provide these tools to these clients at these various locations, 15 different organizations around the state we work with. We were able to feature 2 in Parkersburg because we didn't take them on a grand tour of West Virginia. And, you know, when they ask the questions of the clients, you know, how was this helpful? How did technology help your recovery? You know, it was so moving. You know, we provided this to over 300 people in West Virginia so far. We're getting ready to move into distance counseling. So my question is, you know, how do we see technology, how do you all see technology being a viable delivery modality, and what else can we do to get funds, be it through the FCC or through funding through additional grants? Because we tried this program without providing the phones and the service, and it just didn't work because our clients don't have the credit history to be able to get the contract. They don't have reliable, dependable income, so month to month, phone situations don't work so well for them. But for the clients who got these phones and service and used the app, over and over today, the comments from the clients were, you know, it gave us a sense of community, it allowed us to communicate with each other. It allowed that peer support to happen in a safe, secure environment. I was never alone. And, you know, as many of you all know, this is frequently a disease of isolation and becomes, you know, an isolating condition as people burn bridges, as they, you know, eliminate their resources and friends and allies and people who are, you know, could support their recovery. You know, we're seeing great things happen, and you know, the funding is not there to sustain this application. And so, you know, although today was a very hopeful and really energizing day to be with the clients, it was also difficult because, you know, the grant comes to an end. And so how can we sustain this? How do you all see technology as being a way to promote treatment?
Well, I'd say that we're going to see more and more of these kinds of interventions developed. SANTA, as you know, has a number of these kinds of projects that are supporting all over the country, and to hear these kinds of successes is something that I think will stimulate the continuation of this kind of program. I think that we're going to see a way of telemedicine. I think that's actually one way that we're going to provide greater access to care using someone talking about the need for specialists. I'll tell you that in this country we only have about 7,000 addiction specialists. That's not very many. And we're never going to have huge numbers, at least not for a lot of years. And so we need to make the best use of those folks that we can. And so I think that interventions like telemedicine, I think interventions like phone apps where physicians can and other clinicians can communicate with their patients on a regular basis are also in development. In terms of how you continue something like this, aside from the funding programs that exist in SAMHSA, and I think maybe Dr. Wolcott might speak to this, is what about something like an SBIR grant or the Small Business Innovation Research to continue the development of these kinds of programs once you see the success in a small... Oh, okay, well, there you go. So there's
But, like I say, we're from Wyoming County, we're going to be in this county in the morning.
Here's something that I don't know if we'll know the difference in these two things. people seem to get, like you said, you don't have 10 doctors, 5 pharmacists. And I was canoeing about 8 years ago, got in County River from Wyoming County where I live in Huntington to a conference. On the second day, I flipped my canoe over and I lost 9 plaques because I had heart stents. I found it virtually impossible to replace those 9 plaques because I had a certain amount that I could get, and I couldn't get any more. So I thought, well, I'll take that. Now, for some reason, it was nearly impossible. They knew immediately that I couldn't get any more plaques because I had all I had to have. Well, if that can happen for plaques, surely to goodness it can happen for oxycodone. I don't know what the difference is, but whatever it is, that should put a hole in it.
They're paying cash, that's the problem.
That's right.
Is that it? The cash can flow through?
You could have got your plaques for cash.
I could have gotten it for cash?
Yep.
I didn't know that.
But I think that, and my colleagues can talk about this because this is part of the training. The other issue, though, is really about kind of what is promoted in terms of safe opioid prescribing. People talked about this. Is how do you monitor patients on an ongoing basis to understand that a problem is developing? And so, virtually all of the curricula that train physicians talk about things like doing meal counts, talk about things like doing random drug testing as a part of it to see what's on board. So it actually is part of that protocol. And again, the whole function of prescription drug monitoring programs, again, are to make sure that patients are not getting additional prescriptions ahead of what they should be getting. But I think the scenario that you're talking about is exactly the kind of scenario that we're trying to promote in terms of prescribers and prescriber education, is that so they are monitoring the number that you're taking. First of all, that you don't get more than you need in the first place, and second of all, that they have some good markers and understanding and quite honestly practices about monitoring, are you taking these very powerful medications as they were prescribed.
Yes. So, Wes Dangerfield, the CEO for Summers County ERH. First, I want to acknowledge I was at the National First Prescription Drug Use Summit. You were there. You were at everything. Because everywhere I would go, you would be just in front of me somewhere else. So I appreciate that very much. Appreciate Dr. Volkoff and her presentation that she had there, and many others that were there. The information shared. We came back from that information as what was one of the purposes to share the best practices. So our accounting, the pharmacists, the physicians, the former mayor that was there, including Matthews and others, we put together the task force, we educated, we shared, and we implemented many of those things. Purchased the drug dispensing unit, which they had attached in law enforcement, so someone else with a truck and chained it and towed away, and others. So we appreciate that there's now going to be the pill dragon, or whatever this one's going to be called, to travel around. This will be very helpful to multiple counties. Sort of 2 questions with it. One of the best practices that came about, Pamela Bondi from Florida said they did not have a database. I appreciate the funding that West Virginia had to have our database for that. But she worked with law enforcement to take the tricked out Hummers, Ferraris, Lamborghinis for those that were finally convicted for given the due diligence. Yes, this is someone that's abusing. They sold it. They used the funds for that to create the database. Every state doesn't have it. The states are working towards it. The bandwidth for West Virginia, we were told, at least at that time, had to be expanded so that when other states do get it, that they can share the information. I don't know whether or not that's something that's being looked at to explore the funding of taking the money from that and not having it earmarked for something else, but perhaps to use it as Florida did to improve the bandwidth or other things that would be used for this as a potential option. And I'm wanting to throw that out because the second piece that we're looking to do is, as multiple people commented, this is impacting our community as well as many others. It impacts our ER. So the types of patients that are showing up are either they have abused and they're there, or there's someone else that is impacted at a higher percentage than what has been even just in recent years. So we're looking to structure our emergency room, and we now have to factor that in for what we can do, for what are the other best practices that are recommended that you have it there. So for the funding for that, that's just going to make it more expensive. But is there anything that's being done perhaps to take the funding from what is gained inappropriately to then be redirected from those funds that are captured in West Virginia? Is that going on?
Well, actually, the funds, like I mentioned, to buy these fuel dragons or these incinerators came from a federal foreclosure action against Purdue Pharma. Just those same sorts of things are happening, yes, is a short answer to your question. We have in our office a very robust forfeiture practice to get the money out of the wrongdoer's hands and back to productive use. So, short answer to your question is yes.
Great.
I'll say something else as well. There's a lot of variation state to state, what the nature of the problem is and what kinds of responses. And I think just because we're sitting at the table up here doesn't mean that ideas are going to come from here. A lot of why we believe in supporting states to experiment, explore, and develop approaches, but evaluate them and show the impact of those approaches is because you're going to find creative, unique ways of addressing the problem within your environment. And we're going to learn from that by coming on visits like this, by having grantee meetings and other kinds of things that we do in the nature of providing resources and support to then expand upon those. So, I mean, you should be proud of what you're doing and what you can share. And a large part of our job is being able to share what's happening in different jurisdictions to bring those ideas to bear in other places.
Thank you. To comment on that, Natalie Tennant had come to our county in March, and she was looking to address what are some of the best practices and things. We've gone through this exercise in our county, and we had relayed to her, and I walked her out while she was going to her car because she was running out of time, to write down different things and give it to her assistant who could remember it. And then it was, she came back last week to the county, and she said, here's our plan that she rolled out. 4 of the items that were in there were items that we came up with. Now, were we the first? I don't know. But they were some of the things that's in there. So there are some things that were best practices from the National Drug Abuse Summit. There were some other things that came about from it that said, now go do it. We did it. We came up with some suggestions, and we certainly wanted to share it to be replicated elsewhere. So we certainly would be glad to continue to do that and share with whomever appropriate. Thank you.
My name is Stephanie Else. I work at First Choice, and I'm the current director of the West Virginia Prescription Drug Use Quit Line. We're a 24-hour confidential referral service supported by grant funds from DHHF that come from the block grant. One of the challenges that we see, and particularly in this part of the state where the demand for treatment is so high, is that, for a good reason, there are limits as to how many patients a Suboxone provider can see at a time, and I understand that. However, there aren't enough physicians that have chosen to, and it's a very simple 8-hour training. I've researched it. The grant program that you'll be doing, is that something that you'll be addressing, is trying to recruit those physicians to become certified good providers of the medication-assisted treatments so that when we receive the calls and the people need the treatment, that we can get them what science knows and has shown us works as soon as possible.
So you're speaking of the Prevention Boost grant program, and the bad news is no. The good news is, to the Congressman's ears, that as federal agencies we try to not overlap and do work that's duplicative of what other agencies are doing. And CDC's focus is really trying to work upstream. So we're not focusing on the treatment side, which we absolutely acknowledge is critical. We're not focusing on the existing supply side. We're trying to work to help diminish the supply side. Unfortunately, the gap in treatment services and resources for substance abuse treatment is substantial, and this grant is not specifically focused there. We're trying to work, again, on the prevention side of the supply side.
But we can tell you that this is an issue that we're really very acutely aware of at the federal level, and a number of different divisions of HHS have been providing input to the Secretary for Health and Human Services about the need for more providers and different options by which that might occur. And so those things are being considered, and I suspect that there will be some changes made that will help to improve that situation. In terms of the training of physicians, the 8-hour, as you know, SAMHSA sponsors the 8-hour buprenorphine data waiver training, and we have certified over 25,000 physicians in the United States to provide this care, but we know that only about 7,000 actually are providing almost all of the buprenorphine in the country. So a lot of physicians get the waiver and they don't practice. So we need to better understand how we can work with them to have ongoing, continuing education so that this is a practice that's familiar to them and something that they feel is something that is part and parcel of what they provide to the patients that they serve. We are working on that with others within HHS. We work with CDC, we work with HRSA, and other agencies, including ONDCP and Indian Health Service right now to develop what we're working on is developing implementation tools. We think that one of the reasons physicians don't practice is because the 8-hour training isn't really enough. If you're someone who really hasn't worked with folks that have these problems, it's really not enough to give you the confidence to take on the practice. And so we're trying to work with other of our colleagues within HHS to come up with ways that we can help physicians to feel confident enough to implement these services and expand access to treatment.
One of the other opportunities to explore has been a real federal priority, and I know that things are happening at the state level too, and there's really innovative models, is lifting the cap doesn't solve issues around rural access, right? So it's about, are there other ways to use things like our primary care system, our federally qualified health centers? And, actually Vermont is doing this really interesting model, and getting nods over here because people are sharing, which in very many ways is very similar to West Virginia. It's a significant opiate issue, lots of rural access issues. And so there are a number of, I think, innovations that are happening at the state level to say, how can we increase access to high-quality medication-assisted treatment services by using our existing primary care services? Because often we don't have funding to build brick-and-mortar treatment programs everywhere. So there's interesting work happening, I think, in other states around that issue.
One of the things that we hear a lot at the Board of Pharmacy is that, geez, if the prescribers just wouldn't prescribe this stuff, then that would eliminate a lot of the problem. And so there's always this tug and pull between mandated use of the monitoring program so that the honest physicians will have that information in front of them versus voluntary use, and the tug and pull between having to do it every time versus low reimbursements and they don't have the time. Right now, we've struck a balance with some mandated use in some targeted areas. Is that what you're seeing in other states? And what are the feelings that you are seeing on mandated use of monitoring programs?
So far, our experience suggests that the mandated use increases the effectiveness of changing prescribing behaviors, and that the goals for model systems include mandated use, include the alerting that you provide, include the work that you're working on now, and it would be very helpful to be able to see the impact of it to improve the workflow of the physician so that it's integrated within their health record systems and the sharing across state borders. All those pieces are pieces of a most effective, what Dr. Friedman likes to call universal PDMP. So you have many of the key steps but we are finding that mandated use on every use is a more effective way to change behavior, prescribing behavior.
Sounding much less scientific than it is. Part of this is we're in the middle of an epidemic here. And I don't feel like it's unreasonable to ask physicians to take, a few hours of education to check the PDMP program. I think, Dr. Volkow put it well, we have an urgent situation that requires urgent acts. And I'm not unsympathetic to the challenges of providing healthcare on a daily basis, of working in, managed care minute. I understand that. But I also understand that we have to respond in kind based on the magnitude of the epidemic. And, when I started doing this work at Massachusetts at the state level, I was not a fan of mandatory training. I was not a fan of mandatory prescribing. But as the epidemic continued to grow and the solutions were emerging, my position changed dramatically. And, I think we're not trying to lay the entire blame at the medical community, but we all have a role to play. And I think that we've seen a significant response from many other parts of the law enforcement community, the community at large, the treatment community, and I think kind of asking the medical community to respond is not something extraordinary.
Anybody want to ask the last question that's not asked one yet? Or comment?
No more questions.
If not, did you have a problem?
I'll make a quick comment. In the meeting that was held before the PowerPoint presentation, I believe Dr. Volkow did in Florida, there was a comment made in the late 90s. Pain was something that CMS, Joint Commission, and others were recognizing, and there was a correlation spike for how much things were being prescribed. Coming back and talking with the medical community and then polling other colleagues, other physicians in different states, especially in the Appalachia region, CMS continues, and it's totally fine with the patient satisfaction survey, but they're ranking hospitals, they're ranking physicians and publicly reported. The comment that I would share is physicians are struggling with, they're going to be scored. Hospitals are struggling with, they're going to be scored on pain management. So in the clinic, in the ER, and in the hospital, the balance of patients that already have a higher tolerance, perhaps because of the pain, and if they don't do this, is the reimbursement going to be cut? Is there other changes going to be made? And I just want to comment that it is truly concerning for physicians that are trying to do the right thing, but struggling on that one part. And from the heads nodding, I'm certainly tell different ones know about it, but it is a challenge that physicians trying to do the right thing struggle with, and just wanted to comment about that.
It's a really valid point. We actually just heard this at a medical center in Boston too. What he's referring to is that hospitals are actually penalizing their payments for Medicaid if physicians in the hospitals are poorly scored on how their patients receive their pain treatment. Right? So you're a doc, you're trying to do the right thing. You don't want to give out the prescription, but you're also afraid that your hospital is not going to get the money because your patient is not going to think that they were treated. So it's something that we're working on at the federal level, but thank you for raising that, because it's a real disincentive, I think, for helping physicians to do the right thing.
Well, again, let me thank everybody for being here. I know it's probably getting close to 8:30 quitting time. I thought that said 8:15. Okay. Let me especially thank our panelists for being here. It's been a long day. Tomorrow's going to be even longer, and you've been very patient, very knowledgeable, very professional. And I know I speak on behalf of all of us. We appreciate very much your time and your knowledge. Substance abuse does cost all of us, both individually and in the hearts of our families. Tragedy after tragedy unfolds. Billions of dollars are being lost annually across our country. Abuse cannot be simply snuffed out in one region only to flare up in a neighboring one. So it does take a concerted effort, that cooperative effort we've heard about this evening on behalf of our entire nation to keep this epidemic at bay. CDC has given us an opportunity to lead in West Virginia, and lead we will. Lead we will. Already in towns and cities and in the rural countryside, we are combating the scourge. We have no choice to do otherwise. We did not choose this plague, but our people are no stranger to adversity and challenge. Armed with adequate resources and the means to fight back, we will develop a model for other regions of this nation, and we will ultimately prevail. So again, I thank our federal partners for being with us, our state partners, our local partners, all of the people who have the wherewithal and the desire to combat this problem. Thank you. God bless each of you.
Two things. Please make sure that you've signed in. And state police have one of those.